Hello, everybody. My name is Annelies Zinkernagel. I am the president of ESCMID. A very warm welcome on behalf of GLG and ESCMID to today's conference, the first meeting on forging partnerships between science and policy to tackle antimicrobial resistance, also known as AMR. Antimicrobial resistance is a key strategical focus of ESCMID, the Society for Clinical Microbiology and Infectious Diseases. In our society, we bring together clinical microbiologists and infectious disease specialists from various regions of the world, aiming to optimize diagnostics, improve preventive measures, and optimize treatments for our patients. During the COVID-19 pandemic, we all have realized the value of working together and sharing knowledge nationally and internationally amongst clinicians, scientists, and policymakers. So together with WHO, GLG and ESCMID has built on this momentum, and we are bringing forward and putting together a high-level AMR event. We will start off with 4 keynote sessions, followed by 2 panel discussions, one on preventive measures for AMR, and the second one for catalyzing innovation. With that, I welcome my co-chair, Chris Fern, to moderate, and he's the Deputy Prime Minister and Minister for Health of Malta and the GLG Vice Chair. Many thanks.
Thank you, Annelies. Thank you very much. Thank you and good afternoon, Your Royal Highness, Minister. Annelies, thank you for bringing AMR so highly on the agenda of this wonderful Congress. Antibiotics increasingly are not working. Antimicrobials, antivirals, antifungals increasingly are becoming ineffective, and increasingly we are facing infections which we cannot treat effectively. And this is something which is happening now. It's not something which has happened in the past or which will happen in the future. It's something which is happening now. The figures are alarming. We've seen figures of over 1 million people globally who have died directly because of AMR over the last year or so. If you bring in together the people who have also died from AMR-related conditions, that's up to 5 million people. 5 million people a year is a big number. But it's probably so big that many of us can't even grasp what it means. 5 million people a year means 10 people every minute, every single minute, 10 people around the world are dying because of AMR-related conditions, either directly from AMR or as a consequence of diseases related to AMR. That's 1 person every 6 seconds. So somebody's died from AMR. And somebody's dying from AMR every 6 seconds that I'm speaking, and every 6 seconds of every minute, of every hour, of every day. That is a big number. That is a crisis. AMR is a crisis. Now, I've been health minister for the last 9 years, but by training I am a pediatric surgeon. And as a pediatric surgeon, and as clinicians and people who are in medicine, the audience will know, as a pediatric surgeon, I woke up in the morning, I woke up in the middle of the night thinking about my patients, and I spent every hour of my working life concentrating on my individual patients. When I was operating a child, that child was the only important thing for me in the world at the moment. And this is how it should be. But even as I was operating on a child, I was aware that there were factors outside of my capacity that were affecting the outcome of the treatment I was giving to my patients. And when my little boy, after an operation, went back home, whether he had a proper diet or not, whether he lived in a suitable environment or not, where his family sent him to school, all of this affected the care that I could give, that I could afford to give to my child. And these outside factors, of course, whilst clinicians feel they have very little control over, but these outside factors are political and need a political solution. And AMR, antimicrobial resistance, is a political issue. Now, of course, I'm not suggesting that all of you become health ministers, though I'm sure some of you will probably do a better job than I do. But you can all become involved politically. Individually, clinicians, and collectively, clinicians have more political power than you think. People look up to clinicians, people look up to people in medicine, and what you think and what you say and what you do can influence a lot of what happens even outside the factors that depend solely on you to care for your patients. So yes, you have a lot of political strength. Use it. It could be just as easy as tweeting, and do tweet what Her Royal Highness will say, what the Minister will say, what Prime Minister Motley and what Dr. Tedros will say over the next few minutes. Do tweet, because your tweets are picked up and they will spread the message, or become more involved. But mostly what you can do to help politicians make the right decisions is provide the evidence. The evidence. Now, politics is the art of taking decisions, but not all decisions are the correct decisions. And the keystone of taking the right decisions is having the right data, the right information. And this is where you can come in. To successfully start to manage the AMR crisis is a many-faceted program. The keystone of all of this, the foundation of all of this, is to have the right data. Surveillance is extremely important. I just spoke about the numbers of deaths, 6, 10 deaths a minute in humans from AMR. It's probably more because we don't have the data from all over the world accurately enough. But this is just in humans. We don't know what happens in animals, or we have very little data of what happens in animals. We don't know what happens in plants and in the food crops that we produce. We don't know what happens in the environment. And all of this is extremely important if we are to take the right decisions to bring this forward. And of course, the implementation of national action plans for AMR, for tackling AMR, are extremely important. And the national action plans, by their very nature, because they are national, will deal with the solution, with the problem as it is on the ground in that particular area. And thankfully, a lot of countries, probably most countries now, have a national action plan against AMR, but very, very, very few have specific funding for it. Now, sometime towards the end of next year, the United Nations General Assembly will be holding a high-level meeting on AMR. Our director, the Quadripartite Secretariat, Dr. Haley, will be speaking about this later on today. And this is an extremely important occasion, the high-level meeting on AMR by the United Nations General Assembly next year. And the least we need to aim to get out of this is to have at least a global fund for implementing national action plans. Because unless we do that, the national action plans will remain on shelves, will remain in drawers, and we will not see the improvement that we need to see on the ground. But then, of course, there is research for new antibiotics. We are running out of antibiotics faster than we can produce new ones. We are running out of antibiotics faster than we can produce new ones. And if we need to keep the same level of care that we can give out to our infectious disease patients today, various studies have shown that we need at least one new high-impact antibiotic every 2 years. We need on the market one new high-impact antibiotic every 2 years. That is just to make up for the antibiotics that we are losing because of AMR. Now, because only 1 in 2 products that go into clinical efficiency studies end up onto the market, that means we need 2 products to come into clinical trials every 2 years. So 1 product, one treatment, 1 antimicrobial treatment every year that needs to come, a high-impact treatment that needs to come onto the market. That means, because only 1 in 20 products that go into early-stage development end up in clinical research, that means we need 20 therapies, 20 products that potentially go into to become antibiotics that go into early-stage development every year. 20 early-stage development projects every year. And because only 1 in 25 basic research programs end up in early-stage development, that means we need 500 basic research projects every year 500 basic research projects every year just to have one new antibiotic every 2 years, just to keep the level of care that we can afford now. So for one new high-impact antibiotic, we need 1,000 basic research programs, and that is a lot of money. Now, next week or the week after, there's an opportunity that your minister and myself need to get involved in, and that's the European Union Pharmaceutical Strategy, which the first draft of which will be presented, should be presented on the 24th of April. And within that pharmaceutical strategy there is an initiative to bring funds onto research for new antibiotics. But unfortunately, the initiative that is being proposed by the Commission has already found a lot of resistance from member states, and there is this coordination between the Commission and member states. And this is too big an opportunity for us to miss. So this is not something for you, but something for Sophie and me. Next week we'll be in Brussels, and we need to sort this out. Because if we don't, we lose an opportunity. The pharmaceutical strategy is a big opportunity to bring funds onto the research that you people need to do to give us new antibiotics to be able to treat our patients. So my final appeal to you is this. Move outside your comfort zone, move outside your clinical comfort zone, get involved politically, tweet, speak up, but most importantly, produce the evidence that we need and be the change. Our future and our children's future is in our hands. And now it gives me great pleasure and the deep honor to ask to present Her Royal Highness Crown Princess Mary Elizabeth, the Crown Princess of Denmark, to the stage. And thank you so much, Your Royal Highness, for lending your support to this very worthwhile cause. Your Royal Highness.
Good afternoon, everyone. Minister, Excellencies, distinguished guests, ladies and gentlemen. As a species, humans have always been concerned about their health, and rightfully so. Health is the foundation upon which all aspects of life are built, and is the key to living a fulfilling and meaningful existence. However, despite our best efforts, our health is constantly under threat from various factors. And one of the most significant challenges we face today is AMR, or antimicrobial resistance. As patron of WHO Europe, I fully support and see health as a fundamental human right. And we must work together to give that right meaning, by ensuring all people have access to the health services they need when and where they need them, without suffering financial hardship. Today's event is of great importance in ensuring a healthier future for all. The threats posed by AMR require common, urgent action, and today's event will hopefully further inspire and drive such action. Our experiences from COVID-19 showed us not only the danger of what the eye cannot see, but also the importance of tackling such challenges collectively across sectors and borders, and at all levels of society, and with political priority. Like COVID-19, AMR is not only a microbiological problem, but also a socio-economic problem that can impact many aspects of our lives. Around the world, we are already witnessing the dire consequences of bacteria, virus, fungi, and parasites developing resistance, rendering previously life-saving treatments less effective or totally ineffective. The so-called silent pandemic is not so silent after all. It is the leading cause of death worldwide. It is a leading cause of death worldwide, estimated to claim more than 1.27 million lives a year. And the numbers are set to rise. By 2050, the World Bank estimates that AMR could drive an additional 28 million people into severe poverty and trigger $1 trillion in healthcare costs. the impact of AMR on our health is enormous, and it affects everyone, regardless of age, gender, or geography. Over the past decade, significant progress has been achieved. One of the most significant achievements has been the recognition of the issue as a global health priority. WHO and other international organisations have taken steps to raise awareness of the issue and encourage action from governments, health professionals, and the public. Another achievement has been the development of some new and effective antimicrobial drugs and vaccines to combat resistant strains of bacteria and viruses. There has also been progress in promoting the responsible use of antibiotics, both in human and animal health. Although development of technical innovations is an important dimension of tackling AMR, we must also ensure that existing and new antimicrobials are handled with care and that surveillance systems are strengthened to monitor the spread of resistant strains of microorganisms and the early detection of outbreaks. In this regard, I would like to highlight the WHO Global Action Plan for AMR, launched in 2015, which has been instrumental in catalysing change. It has inspired action across the One Health spectrum, and currently 166 countries have developed national action plans for AMR. Despite progress, more action is needed. AMR cannot be addressed in isolation. It is linked with other important global agendas, such as achieving universal health coverage, the Sustainable Development Goals, strengthening health systems, addressing food security, and responding to the climate crisis. To overcome a challenge of this magnitude, AMR clearly demands collaboration across borders, sectors, and competing agendas. The global recognition of AMR also as a socio-economic challenge is crucial. During my travels, I have seen firsthand how limited or no access to effective antibiotics leads to devastating consequences for people most in need, the most vulnerable. This emphasises the need for context-specific interventions that address the multiple challenges countries face. In low and middle-income countries, already fragile health systems face a higher frequency of critical infections against a backdrop of limited sanitation and hygiene and sporadic access to diagnostics and regulated medicines. These conditions exacerbate the threat of AMR. For women, these factors are only made worse by socio-cultural norms and limited access to education and health information. Women are more exposed to antimicrobial use and resistance due to biological factors, their type of employment, and their role in home-based care. In fact, women are 27% more likely to receive an antibiotic prescription in their lifetime compared to men. In response to this, Denmark initiated in 2018 the International Centre for Antimicrobial Resistance Solution, ICARS. Its mission is to partner low and middle-income countries to co-develop, test, and scale up context-specific solutions to AMR challenges. ICARS, now an independent international organisation, has initiated several mutually beneficial partnerships in low and middle-income countries. Today, AMR is a global health priority, and global governance for AMR has been strengthened with the formation of the quadripartite collaboration and the Global Leaders Group on AMR, which serves as a driving force for building continued momentum and political action. AMR is a complex web of connections that can be hard to untangle. It's easy to get lost in the technical details and forget about the real-world impact that AMR has on people's lives. To break through the complexity, we need to find a way to weave together the science and the policy with the human-based stories behind AMR. By doing so, we can better understand the problem and its urgency, making it easier for everyone to act against it. By bringing together researchers, policymakers, and politicians, today's meeting can provide a significant contribution to tackling AMR as the global threat that it is. COVID-19 has taught us that no one is safe until everyone is safe, and that no one person, organization, or country can solve such challenges alone. Let us build on that experience to help us overcome the global health challenge that AMR is. Thank you.
Thank you so much. Thank you so much, Your Royal Highness. Thank you so much. And thank you so much for your continued support in tackling this world crisis, as you point out. It's now my pleasure to introduce, this time virtually, the chair of the Global Leaders Group, my good friend, the Prime Minister of Barbados, Mia Mottley, who is joining us from Washington. Thank you so much for being with us, Prime Minister Mottley. And as usual, you're not only the chair of the GLG, but you're also our inspiration. So thank you so much for being with us, and the floor is now yours.
Thank you very much, Chris. Your Royal Highness, my dear friend, Dr. Tedros, ministers, distinguished guests all, good afternoon. I do speak to you from Washington, D.C. at this point in time, because we've spent the week trying to see how we can create a framework that will allow for the effective financing of global public goods. Look, I don't think I make a speech now without referencing this slow motion silent pandemic. And why? Because if each of us stops, we can almost know somebody who has died as a result of the inability of antibiotics to help them with some kind of hospital-aided infection, invariably. And as you heard from Chris, more than 1 million people die directly every year, and about 3.5 million people have deaths associated with AMR. The rate at which the big pharmaceutical companies are working for therapeutics for us to be able to find solutions, to be able to fight these viruses, is perhaps not as strong and as quickly as we would like. And we all know that that is because the economics of antibiotics just don't compare to the economics of other medicines that people have to rely on for a much longer course of time. This is unsustainable. And this is partially the message that we've been bringing in Washington, D.C., especially for the reform of the World Bank, that there needs to be a determination as to what are the global commons. What should the global commons look like? What are the global public goods that we should be providing? And on the top of everybody's list after the climate crisis is, in fact, pandemics. The only problem is that they're still in a frame of mind to think of pandemics only in terms of COVID. And the truth is, we all know that what lies ahead of us can reverse a century of medical progress. You have heard from Your Royal Highness, Her Royal Highness, you've heard from Dr. Hearn, that these things are literally piercing into every aspect of our social and economic life. And if we don't get it right, it will undermine how we live and indeed how much we spend on what we have to do to recover, particularly with the loss of productivity that will come thereto, with the loss of human lives. I want to urge those there in Denmark, I wish I could be there with you in Copenhagen, but I want to urge you to continue in pursuit of making the strong linkages with the science, because we must follow the science. And we learned that very, very, very clearly as we dealt with COVID-19. But with the science must come the grounding in the economics of it. And if the economics of it does not make sense with financial returns, then we have a national and international obligation to find the funding to be able to allow us to protect our people. I want to wish you all the very, very best, and I want to suggest that our work must continue apace to the high-level meetings that we will have at the United Nations next year, in the hope that we can carry the awareness of this issue to an even higher level among our populations. I believe, Dr. Tedros, that you have been successful in ensuring that the WHO has pushed this, but along with you have also been the efforts of FAO, UNEP, and OIE. And to that extent, as we heard earlier, there is still so much more to be done with respect to understanding its impact with plants and with livestock, and ultimately with the environment. Let us to the task continue, and I wish all of you very, very much the very best as you undertake this important meeting in Copenhagen. See you soon. Thank you.
Thank you, Prime Minister. Thank you, Prime Minister Motley. Thank you for being with us, and thank you for your leadership in this important quest that we have. It's now my pleasure to invite Her Excellency Sophie Lord, Minister for the Interior and Health here in Denmark. Once more, thank you again for hosting us here in this lovely city. Sophie, the floor is yours.
Thank you. Your Royal Highness, Ministers, Excellencies, ladies and gentlemen. Our health depends on antibiotics, but we're heading toward a world where antibiotics are losing their life-saving effects. AMR poses a great danger not only to our health, but also to our effort to achieve the Sustainable Development Goals, and it undermines economics worldwide. This calls for urgent action and long-term solutions. So thank you so much to the Global Leader Group for this important initiative, and to all of you for being here today as we attempt to put a face on AMR. To combat AMR, we need a cross-sector cooperation on all levels. We need science and policy to work together hand in hand. We have to show the world that it's possible to both mitigate AMR and to ensure access to effective antibiotics. By building a strong link between policy, research, and practice, we can develop tools that include both push and pull factors in order to ensure access and a sustainable supply of antibiotics, both old and new. And at the same time, we must reduce the need for antibiotics in our health and animal sector. And keep in mind that all use of antibiotics contributes to drug resistance. To do so, a clear and dedicated One Health approach is a very important element. In Denmark, we have a long-standing tradition of working from a One Health perspective. For instance, we have been compiling data on consumption and resistance among humans and animals. In fact, Denmark was the first country to monitor AMR across the One World Health spectrum. It has been vital for the significant reduction in antibiotic use we have achieved in the last decade, and this achievement is the result of all sectors working together on all levels. But it is equally important that we reach out and promote the One Health approach on a global level, because the challenge of AMR affects all countries, yet the context of combating AMR is different in every country. The burden of AMR is especially high where resources are low. Solutions need to be led, developed, and owned by countries. This is the mission of ICARS, the International Center for AMR Solutions. So far, ICARS has set up more than 30 projects based on a One Health approach, spanning across 16 low and middle income countries. ICARS and its partners have shown real results in their work so far. And as more partners join the work of ICARS, even more results will come. Denmark invites all countries to partner with ICARS. The mission is to respond to the demand for solutions to AMR. I'm confident that we together can turn the tide of AMR, but we have a long way ahead of us. Therefore, I'm pleased to see so many of you present today, also online, representing different sectors, different perspectives, but all with a common goal. Today, we are one step closer to putting a face on AMR. Thank you.
Thank you so much, Minister Lord. Thank you so much. Thank you for your strong message and thank you for your support. You can maybe have a seat with us. Now it's my pleasure to, again, virtually invite the Director General of the World Health Organization, Dr. Tedros Ghebreyesus. I believe you are with us. Tedros, there you are. Thank you for joining us and thank you for your leadership over the years of the pandemic and now over this new, well, not so new, but over this crisis that we are facing again globally. Dr. Tedros, floor is yours.
Thank you very much, Deputy Prime Minister. Thank you for also moderating this session. Your Excellency, Prime Minister Mia Mottley, Your Royal Highness, Minister Lude, and colleagues and friends. Thank you to the Global Leaders Group on AMR and the European Society of Clinical Microbiology and Infectious Diseases for inviting me to speak here today. I thank you for your support and for hosting this Congress in Denmark, Copenhagen. Tak skal du have. I'm sorry that I'm not able to join you in person. Forging partnerships to help translate science into policy is what WHO is all about. And it's of course also true for AMR, which has such serious implications for human, animal, and plant health, the environment, food security, and economic development. This forum provides an important bridge between scientists and policymakers, researchers and politicians, laboratory specialists, and legislators. I commend the political momentum created by the Global Leaders Group over the last 2 years, with leadership from the chair, my sister, Her Excellency, Prime Minister Mia Mottley, and the Vice Chair, Deputy Prime Minister Chris Ferne, and its members from governments, foundations, civil society organizations, and private industry across the One Health sectors. Advocacy by the Global Leaders Group and others for action on AMR must be informed by evidence and science, for which we rely on you in research and academia. We need to work together to develop and finance innovative solutions to the research and development pipeline and access crisis for new antimicrobials and alternatives to antimicrobials. We need new diagnostic tools, better vaccines to prevent disease in humans and animals, new approaches to antimicrobial waste management, better understanding of AMR in the environment. Also needed is innovative research on behavioral change to help translate evidence into action. So, as you come together as leaders and researchers to share your discoveries and results, I want to express my gratitude for your work to bring together science and policy on AMR. It's through this type of dialogue that we will turn knowledge into the action needed to save the lives of millions of people around the world. I thank you. Tak skal du have. And back to you, Chris.
Thank you so much. Thank you so much, Dr. Tedros, and thank you for so vigorously leading one of the prongs that we are bringing together to try to start tackling this global crisis. And with that, we come to the close of the first keynote session, and I thank Her Royal Highness Crown Princess for being here with us, Mr. Lode, Prime Minister Mottley, and Dr. Tedros. A very high level session, some very strong messages today, and as I've appealed to you before, do tweet so that you spread the message across all your followers and friends. And with that, I think we will now change the scene, so that we'll bring on the first panel, which is talking about prevention of AMR and lessons learned from COVID. And once more, I thank all the speakers from this first session. Thank you so much. Thank you. Great honor. Thank you very much. Thanks a lot, Minister. Thank you very much. Thank you.
So with that, we'll start with the first panel on preventive measures for AMR, COVID-19 lessons, and the role in research. The following three speakers will be focusing on what we learned during the COVID-19 pandemic, both in Europe and in India, and they will be discussing topics such as data surveillance, public health crisis, and the need of rational antibiotic use. With that, I would like to introduce our first speaker for this session, Chair of the Digital Health Cluster at Hausler-Plattner Institute in Potsdam and Professor of Digital Global Public Health and member of the GLG, Professor Lothar Wieler. Many thanks.
Professor.
Yeah, ministers, Her Excellencies, colleagues and friends, it's a pleasure, it's a great pleasure for me to talk here. And impressive first session, very strong messages, I have to say. So I can only add some details to what has already been said, because the magnitude of the challenge should be at least known to each of you here in this auditorium. I want to talk about briefly the parallels between a crisis that hit the world end of 2019, beginning of 2020, the COVID-19 pandemic, and want to work out some issues. And I'm basically here concentrating on information issues and data issues mostly, which are parallels between AMR and this COVID-19 pandemic. To sum up, everybody who before thought about a putative pandemic knew that a pandemic is not a health crisis only, but is a social crisis, a societal crisis, and in particular, you need strong public health systems to tackle such a crisis. So this was now basically felt by each and every person on this globe, I would say. It has been a global, individual, political and social crisis on these levels. Particular, and Her Royal Highness already touched this very intensively, social inequalities were shown in particular like in a focus, and everybody could see this. The burden of disease was tremendously, and this is something I want to focus about, evidence-based data were so much needed for action. And this is exactly why we're doing, for example, surveillance, because we want to make action out of data. And COVID-19 proved that we need to do it, and we should use this for the AMR tackling also. And something that's also very important, and we're doing a lot of research here when it comes to prescription, for example, of antibiotics. Of course, a pandemic is driven by human behavior. And AMR is also a lot driven by human behavior, by the interaction between patients and doctors, for example, but also from many other issues. And I don't want to talk about this today, but I want to talk about data, information, and those institutions that need to be trusted to bring this data to the world. This paper has now been cited by, I think, 3 of the speakers already. And the most important issue here, the number is high. Yes, indeed it is high. However, something that is even more striking, these numbers were only produced in 2022. Yeah? We know the AMR crisis since a long time. But I can tell you that, for example, colleagues of the Robert Koch Institute, which I was the president before, when they reached out and talked to the Institute of Health Metrics Evaluation, thinking about such a project, the people there didn't believe that the numbers were so high, to be very frank here. And so it shows how important it is that you have right numbers. Otherwise, how can you make decisions? And this is the paper, and it's really important to read, and all of you should take a look at it. Because this is the first time we have a reliable number of AMR death and burden of disease, which is even more important. We have to concentrate on the burden of disease, and this is a fantastic paper to go through. So we are the Global Leaders Group, and I'm really happily representing this year. This Global Leader Group works on the One Health issue, and I just show you this one slide here to make clear what the One Health issue is. It's the interlinkage between different ecosystems, it's the interlinkage between different habitats, and it is clear for now, for all of us, that humans and animals suffer from infections with antibiotic-resistant bacteria, also with other pathogens that can't be treated anymore, particular parasites. There's a huge burden of resistance worldwide. But the environment plays a key role also, mostly currently, as far as we understand, by transmitting pathogens to these other animals and humans. And therefore, it is very obvious to understand the problem, you need data from these different habitats and ecosystems, and the data need to be integrated, and the data need to be valid. This is very important, otherwise you may have false decisions. And I want to bring back to you the 4 strategic priorities of WHO. I guess most of you know these. Stepping up leadership for the AMR response, driving public health impact, and I can't really stress this enough. Public health is such an important issue here. Research and development for better access to quality AMR prevention and care. And here I stress prevention, because each and every infection that is prevented doesn't need antibiotic treatment. That's really important. And of course, and this is the topic of my talk, monitoring the AMR burden and global AMR response, and how do we do this? So there is the need for surveillance. And this has never been shown more clearly than during the COVID-19 pandemic. For public health experts, this is obvious, and we already knew this before. But now everybody understood how important these data are. And please don't forget about it. And all of us, please make it happen that we have good data, reliable data. And this starts already in the lab. We need digital solutions, and this is a topic that I will do my research on in the next years. But of course, the data need to be of sound quality, and it starts all in the lab of the diagnostics, and therefore we need educated people. Otherwise, the data are false. So we need data on a local, national, and global level, and we need this circle of making out of data action, bringing it into the clinics, bringing it to politicians, bringing it into the hospitals, and of course also to the medical doctors, because in the ambulatory sector, in those countries where you have this clear decision, most of the antibiotics are used, because the prescription behavior of practitioners is much different to the behavior of the patients, and then it differs very much between different countries. So without sound data, we can't have a baseline to enhance prevention and control. This is obvious, everybody knows it. However, if you look into various countries, the standards are very different. And this is something I want to stress here, we need it on these different levels. But again, if you go through single countries, you see that still, basically, in each and every of these countries, data are siloed. Data from the medical area are siloed, and data from the veterinary area are siloed. And why is this? This is something we should think about, because there are so many people under the One Health issue doing research, but to be very frank and honest here, the linkage and the interaction between this data and the understanding of the data, even in a single country, is really bad so far. So we need to move this ahead. And this is one of the most important issues I want to stress here. So a second issue that I want to stress: who are those institutions that need to be trusted and make sense of the data and present these data to the public, to the medical doctors, to the medical area, and to the politicians? We need strong public health institutions. This is of utmost importance. And I'm a member of the executive board of the IANFI, the International Association of National Public Health Institutes. And this is something we talk about. It's so important that you have sustainably funded national public health institutes, because these have been the institutions that provided, among others, COVID-19 data, surveillance data. And these are the ones who need sustainable financing to also present the data of antibiotic use, antibiotic infections, resistance bacteria. And this is laid out in the 10 essential public health operations, EFOs, and a strong national public health institute is able to do work in all of these different areas. But there is a huge difference in all over the world in various countries. But this is the ideal situation. And we need sustainably funded, legally founded, scientific, independent, really strong national public health institutes. And these need to be trusted by the public. And this is very important. And these can't be denied by political decision makers. This is very important because they are a particular role, and I think I can't stress this enough, how important trust is. And there I come to the basically last point, the third point that I want to make here in this brief talk. We all understood that communication is a very important issue, and we all know this has been framed by WHO, the term infodemics, meaning too many information, too much information, but particularly too much false information. So actually, this is the first pandemic that really was driven by various technologies and social media. They have been at the heart of communications, and they absolutely amplified these infodemics. Another reason why I moved into a new position, to make really use of this and understand what's going on there and how we can influence it to a better. The term infodemic refers to the overabundance of information, including misinformation. This has been at the core. In many countries, we have such a disruptive communication. In the country that I'm living in, Germany, particularly strong. For example, the resistance to get vaccinated, vaccine hesitation, false information about side effects of vaccines has been so strongly put on the agenda in Germany, but also, of course, in so many other countries. In some countries in Africa, from the beginning, people didn't want to get vaccinated because they simply didn't trust the governance, they didn't trust the science. So we need educated people. We need educated people to make this a better world, because if you don't understand the problem properly, how can you manage it? So infodemics is something that we really need to tackle, and I'm thankful to WHO again taking leadership here also in this area, which actually is not one of the core areas of WHO, which is anyway underfunded. But it's great that they take this opportunity, and I hope that all national public health institutes and many, many people here in the phone will also understand that you may have the best technologies, but if you don't bring it to the people, it's useless. So you need to be communicated. So learning from COVID-19, what can we learn from it? From an effective collaboration to tackle AMR. We need trusted institutions between countries and regions, between different One Health sectors, and we really have to encourage and support young people, very important. We have fantastic people coming up. Many young people want to take responsibilities. You see it in the climate crisis activities. We need these people. We have the people in the world. They want to make the world a better place. We need to respect expertise from different sectors. Each One Health sector has particular expertise. We have to respect them and work together. And we have to bring the languages together, and of course we have to promote sector-specific expertises in addition. Without properly educated professionals and people, we can't manage it. We have to make clear responsible roles. National Public Health Institutes are at the core. They need to be strengthened, they need to be coordinating, they need to be sustainably funded, they need to have proper competence. And of course, they have to align with all these intersectoral approaches. And important, and WHO is doing here a great job since years, of course. We have to define common goals and guidelines. The Global Action Plan has been mentioned. In 160 countries now, national action plans have been implemented. Some of them are sitting on the shelf, but they need to be taken from the shelf and put into action. This is what I call output. I like to have outcome, colleagues. Outcome is what you need. And of course, we should end the non-medical use of antibiotics. So the take-home messages. AMR is a complex One Health problem, and as such, like COVID-19, it is a public health crisis. We need to act now. Prevention of infection, this is the first issue here, because each and every prevented infection saves us antibiotics. Surveillance is a baseline strategy that enables prevention and control, because without data and valid data, you can't transform into action. And there's an urgent need to bring these different siloed surveillance tools together. Technological, it's doable. There are various issues here we can solve, but legally it's complicated, and the sectors have to open up. And sound data on AMR use and consumption, of course, are needed to do this evidence-based informed decision-making. And the key ingredients that are needed to catalyze an effective collaboration among these different sectors relevant to AMR are trust. This is the number one issue here, trust. What can we do to gain trust? Respect, defining clear roles, and defining clear goals. Thank you so much for your attention.
Come on. Thank you very much, Professor Wheeler, for bringing forward the importance on data management and making sense of the data, taking a One Health approach, as well as dealing with infodemics. And we're looking forward to discussing these topics afterwards in the panel. So with no further ado, I'd like to introduce Gangadip Kang, Professor of Microbiology at the Department of Gastrointestinal Sciences at the Christian Medical College in Vellore, India, and she's here as an ESCMID speaker. The floor is yours. Many thanks.
Thank you for the introduction. So I'm going to speak for 1.4 billion people, so no responsibility whatsoever. So I think I'll start with this. If you look at the bullet points there, that's actually a prescription for one patient who had an SpO2 of 96 and was intended to be managed at home. You can see that this was May 2021, well into COVID-19. What you can see there is that the prescription included ivermectin, hydroxychloroquine, an Indian antiviral, which was favipiravir. It had 2 antibiotics, third-generation cephalosporin and doxycycline, and a bunch of other stuff. And we thought it wasn't such a bad prescription because it didn't also have steroids. But this is what was really happening in India. And I think the most important lesson here is that fear drives over treatment, particularly when drugs are easily accessible and there is no negative consequences for irrational therapy. India had, there were messages that were circulated on WhatsApp on what you should be doing because access to hospitals was an issue and people who needed care couldn't get it. So they found whatever sources of information they could get. They found whatever drugs they could get, and that actually wound up creating a black market for COVID drugs in India. Remdesivir ultimately had to be rationed by the government because it was being used for everybody outside of hospital and in hospital at a stage where it was no longer valuable. So this was the situation in India. I said, I thought it was a good prescription because it didn't have steroids, because the bulk of prescriptions we saw, even in the outpatients and for many hospital facilities, included steroids. This resulted in mucormycosis in India, This was not something that was seen anywhere else in the world. And in northern India, over 30,000 cases were reported, to the extent that there were mucormycosis wards in our hospitals. So this is really irrational drug use. In our hospital, we had 4 cases in hospitalized COVID-19. All 4 of them had been treated with steroids outside our hospital and were then referred to us for management. So this, of course, was use of steroids, but what does irrational antibiotic use mean in this setting? Well, in LMICs, the big question we always have is, when do you need access and when are you dealing with excess? And if you think about access, when I was a medical student in my state, infant mortality was 125 per 1,000 live births. It has now declined to under 20. This is a state that in general offers better health care than the rest of the country. But this is a pattern that has been seen across the country. Now, where we are today is that even in infant mortality, most infants die around birth or shortly after birth. It's perinatal and neonatal deaths that contribute to about 40 to 60% of infant mortality. Neonatal sepsis in outborn babies as well as in inborn babies is high. It's driven mostly by gram-negative organisms, and we see very high rates of resistance, particularly Klebsiella, E. coli, and increasingly Acinetobacter. Most of the neonates that we have don't wind up in ICUs like you see in this picture. So the government is trying to address newborn care through infection control practices and other approaches, but it takes a long time to build the systems to be able to execute that. And in the meantime, if we look at what's happening with antibiotic use in the community, we've done studies that show us that by day 3, about 2/3 of all respiratory infections and fevers are receiving antibiotics, and usually multiple antibiotics. And for diarrhea, about 1/3 by the 2nd day. So antibiotics in India are used everywhere, not just in people, but also in animals. And we have what is shown here, a formal poultry farm. But we also have a lot of backyard agriculture, and the backyard can sometimes mean a drain. So we have very different animal-human mixing patterns than are seen in high-income countries. And we have to deal with this entire spectrum when we think about what needs to be done. And I'll take for you the example of colistin. Colistin-resistant bacteria were reported in India in meat, mutton, fish, fruits, vegetables in 2018. And in that year and in the preceding years, China had exported about 100 metric tons of colistin premixed animal feed to India. Colistin was ultimately banned in 2019. But we have not seen a reduction in colistin resistance after this. So this is a complicated picture. My colleague, Dr. Balaji, who's here, has just done new genomic studies that are cross-sectional studies that indicate that the resistance patterns and the mechanisms of resistance that we are seeing in animals and in humans are different patterns. So there doesn't seem to be a mixing. Some other studies in other parts of the world have also shown the same thing. But yet, when we have looked at antibiotic usage data, or if we had looked at enteric pathogens in the kinds of settings that I'm describing here, we see that there is actually transmission of bacteria, viruses, and parasites between animals and humans who live in close proximity. So the antibiotic resistance genes have to be traveling. Is it that we are not in the right place looking for them at the time? So in this situation, what tools do we have? And from COVID-19, we learned a number of things. One of the things we learned was that people can actually wash their hands and use hand sanitizer, but only if they're terrified. So that's not a good policy to put in place forever and ever, but I think it does offer to us an important lesson that we need to be able to learn how to do this well, how to do this consistently. And there are many approaches that have been taken that are relevant. One of them I'd like to highlight is something that if I, as a scientist, was sitting down and thinking about it on paper, I would think, brilliant, this is so simple, anyone can execute it. And essentially, it's the red line campaign, which is on every antibiotic blister strip. You have a red line that tells you that this should be given only with a prescription. My colleague Sujit Chandi, who's going to be joining ICANS, actually did a study that showed that in the highest educated state in the country, neither doctors, nor pharmacists, nor patients understood what the red line was about. So I would have thought it was simple. It clearly did not work. So when we design our policies, I think there is a lot more that we need to be thinking of. I'll come now to my final section, which is to talk about one of my favorite organisms. I don't particularly want to have it grow, but unfortunately in India, that's not the situation. Like COVID, typhoid is something that is very familiar in public perception. But if you talk to doctors, and certainly if you talk to doctors before the pandemic, they thought, really, you don't need to do very much for typhoid because we have very effective antibiotics. And shown on the graph there, in the orange line is the increase in azithromycin usage over the first 10 years of this century. This resulted in a decline in typhoid isolation in tertiary care facilities to the extent that when typhoid vaccines were being used in the state of Delhi, doctors were objecting to the use of the vaccine. We've been looking at typhoid for quite a while, and many colleagues here and elsewhere have also looked at it. And there is a clade, a lineage of S. typhi, originally called H58, now renamed. And it was believed that India had essentially seeded the world with this clade. There have been further studies that have been done that showed that this clade did travel to Southeast Asia and to Africa and then spread around the world. But one of the things that happened was that as this clade traveled, it also evolved. And we had the emergence in Pakistan of an extensively drug-resistant S. typhi. This had both plasmid and chromosomally mediated resistance genes, and this is a pattern that we are seeing increasingly with the new strains of S. typhi that we are identifying. So in this background, in order to generate evidence, we started a study for surveillance of enteric fever in India. I'm not going to walk you through it, just to tell you that the incidence of typhoid that we discovered in our population was over 1,000 per 100,000 child years of observation. So what you see in a tertiary care hospital and what you see when you actually go out into the community and look for infections is two different things. And in some of the locations, this was a study done in 18 sites, 80% of the children were on antibiotics by day 3 of any fever, whether or not typhoid had actually been proven. So we've subsequently worked with collaborators around the world to look at the international spread of antimicrobial resistant S. typhi. And I think this graph speaks for itself. India has been traditionally the home of typhoid for hundreds of years, similarly for cholera, and we have spread it around the world. We used these data to talk to our government, and we gave them different scenarios, talked to them about what was happening in Pakistan, what was happening in India, and made the case that typhoid vaccination would be a good approach to take. We modeled what this would mean in terms of typhoid over a period of 10 years. And the government now, with COVID-19, has become very willing to listen to experts. We actually now have a recommendation to introduce typhoid vaccines into the national program in India. Hasn't happened yet, but it's been promised. I will give you one final example of another vaccine that I work with. This is the rotavirus vaccine, where we made a vaccine in India. And in order to introduce this vaccine into the program, we had to prove there was enough rotavirus in the country to do it. And we did a study across India that showed that 37% of all children hospitalized with diarrhea had rotavirus. We introduced the vaccine in 2016, scaled it to the whole country by the end of 2019, and this is what the picture of rotavirus looks like. The solid blue line of a seasonal virus begins to go down after the vaccine is introduced. But more important than that, this was just rotavirus diarrhea decreasing, but we had an overall reduction of diarrhea of 20 to 30%. And very gratifyingly, this meant that there were 2 fewer courses of antibiotics in the first 12 months of life. So just to summarize, I think irrational antibiotic use was brought to the attention of policymakers during COVID-19. I hope this is a message that they will get and will use to be able to have interventions that can make sure that we do have a focus on AMR. There is complexity in solving for both access and excess, and that requires an understanding of where you need to do what, as was highlighted by speakers earlier. Some interventions have had effects, others have not, and we need to understand the reasons for that. And finally, vaccines do hold the potential for lowering antibiotic use and hence decreasing AMR. COVID has taught us a lot. It's taught us that if you can bring scientists and policymakers to the table together, good decisions can be made. Thank you.
Many thanks, Professor Kong, for your beautiful overview and for bringing insights from India to this room, particularly focusing on the importance of the use or overuse of antibiotics and vaccinations. So we'll be following up during the panel discussion. And with this, I would like to introduce our next speaker, the Director of Infectious Diseases Section at Verona University Hospital in Italy, Professor Evelina Tacconelli. The floor is yours. Thank you, Evelina.
Good afternoon. Really honored to be here today. So this is my declaration of interest listing the no-profit organization providing funding for my research in the last 5 years. So the talk today will cover a few different aspects. So I will start with lesson learned or not learned before COVID-19 pandemic. I think it's very difficult that we can keep planning what to do next if we do not understand what went wrong before COVID-19 pandemic. I will try then to link this experience with what we learn after COVID-19 pandemic. I will give you my understanding of the role of the research based on our experience during COVID-19 pandemic, what we believe is very urgent and cannot be delayed anymore, and what can be done in the preparedness plan to try to use the experience of COVID into the fight against antimicrobial resistance. The talk will be very much focused on my experience in Europe, and for the sake of time, I'm not covering One Health approach of antimicrobial resistance. I participated to hundreds of meetings trying to discuss with several colleagues which is the solution for the antimicrobial crisis. But never happened that somebody just stood up and said, it's our fault. It seems that there is no one responsible for the antimicrobial crisis. And I believe that until we understand all the mistakes we have done as a community, as hospital, as country, as government, with a global mea culpa, it's very difficult to find a solution, again, if we do not understand what went wrong until now. There are 4 different reasons why it's so difficult to find a solution for the antimicrobial crisis. The first one is that antimicrobial resistance is extremely heterogeneous. So you might have a huge differences in resistance rate even within the same city between 2 different hospitals. This is just a figure illustrating the cephalosporin resistance in Klebsiella pneumonia among European countries. And you can see the difference among the states has also another meaning. This translate as unequal healthcare standards for citizens. And I think this is ethically unacceptable. The second major point is that there was for years a very huge underestimation of the role of infection control in fighting antimicrobial resistance. This is the WHO priority list. We support WHO with development a few years ago. And we created criteria. And based on those criteria, the experts all over the world decided which were the most dangerous pathogens in need of new antibiotic. Among these criteria, obviously, infection control was included, but was the lowest priority, had the lowest weight among all the other criteria. Underline again that for medical doctors, clinical microbiology, infectious disease, the infection control does not have a role in preventing antimicrobial resistance. The third issue that we never learned to link in real life antibiotic policy with antibiotic resistance and infection control and prevention. This is a systematic review that we completed a few years ago, and we clearly demonstrated that if you introduce in a hospital antibiotic policy, you will reduce antibiotic resistance. And the best effect, 66% of reduction of resistance, is when you link together stewardship of antibiotics with infection control, in particular if you focus on hand hygiene procedure. And if you work in wards, as we do every day, you know very well that there is no antibiotic policy working if you have still transmission in your ward. And there is no possibility to give proper empiric recommendation for therapy, neither for surgical prophylaxis, if you do not have proper surveillance data. And is it possible to translate this into real life? Yes, it's possible. This is the experience that we had when I got back to Italy nearly 5 years ago. So I was working in a high endemic hospital, and we introduced this program that is called SAVE. So the idea was save antibiotics to save life. And linking together, again, in the same team, infection control, discussing every day about antibiotic policy, we were able not only to reduce the antibiotic usage as expected, we reduced also the resistance rate of multidrug resistant gram-negative bacteria, but what was very much important for us is that the effect was consistent during the whole COVID pandemic. So which is the list of the lesson that, in my opinion, we did not learn before COVID-19 pandemic? Why we were so hit from COVID? Because we did not understand how much important was linking together infection control and antibiotic policy, because there was insufficient awareness of the importance of infection control, not only in the hospital, never forget long-term care facility and nursing homes. There was insufficient political commitment. There was severe underinvestment in research. There was limited evidence in vulnerable population, insufficient educational activity, underpowered personnel in infection control. And in my opinion, and we never discussed about that, in several countries there is insufficient consideration of the important role of conflict of interest of prescribers and the role of pharma company in the introduction of new antibiotics into the market. So I think that when COVID arrived, what COVID did indeed just brought into sharp focus the failure of not having efficient infection control and antibiotic policies on site. And we immediately realized with colleagues that the population at risk of severe COVID-19 overlaps within the population at risk of resistant infection. So the question that we would have liked to ask immediately to the government at the beginning is, so will the society continue to accept all these avoidable deaths if the effort to fight resistance is marginal compared with the effort that has been done and is still ongoing against COVID-19. And COVID-19, when it arrived, hit the hospital also in terms of antibiotic usage. So the antibiotic usage we have seen from speaker before was very much impacted by irrational antibiotic use during COVID-19 pandemic. This happened also in high-income countries. This is a systematic review of literature. You can see that different reports from Italy, Spain, and France are reporting that around 50% of the patients hospitalized with COVID were treated with antibiotic. So the question now is, were they treated because they had an infection before, bacterial infection, concomitant to COVID, or were they treated because they acquired an infection while they were in the hospital? There is a nice paper cited on the right side of the slides, where the colleagues just followed 157 patients with COVID and proven bacterial disease. 88% of these patients, they had healthcare-associated infection. So this means they were probably avoidable. And how much this was part of the COVID-19 burden has not been established yet. COVID-19 showed also the bleak landscape of non-existent or difficult to change guidelines for infection control and antibiotic policy in several countries, in several hospitals. So the first comment that I would do here is that what we need mechanism for rapid development of evidence-based guidelines, which should be calibrated, tailored on local epidemiology and availability of diagnostic and antibiotics, which is very different from one country to another. It's very difficult to implement guidelines at global level. So we should find a way to calibrate these guidelines at local level. And we did it. This is a nice experience we had with the Italian Agency of Medicine. And we produced two documents, I think they are the first in this kind, where using the great development methodology, so we use the evidence base produced by international guidelines, and then we calibrated that experience and that evidence based on what is available in Italy, which are the way the doctors, they produce diagnosis, and which is the epidemiology. And what we also did, we applied an antimicrobial stewardship approach. What means? Means that we decided to stop providing doctors with a list of antibiotics as a first line, because this is a huge mistake. What we did, we tried to select the antibiotic, even if they have the same efficacy efficacy against a bacteria according to the ecological impact of that specific bacteria into these guidelines. What also COVID did show the need to link research resources to fast and effective delivery of new cutting-edge evidence. And for sure, there are several examples on how this can be done. UK platform for research, the recovery trial gave an excellent example. I think a great platform in Europe, and probably Mark Bontan will be reporting about that later on, gave an excellent example on how you can run a randomized clinical trial when you need. What also we discover is that the importance of the cohort in producing new clinical evidence. This is the Orchestra project that we lead. It's a huge project where we created 44 new prospective cohorts, mainly working on vulnerable population and post-COVID effect. And we understood how important it is to provide this data to design randomized clinical trial. And what we discovered also is the importance of the data. So there are a lot of interventions during COVID-19 were limited or delayed because there was no way to link data. And why? Because there are a lot of problem and inconsistency in the way the different countries apply GDPR. The common standard for variables does not exist. There is no interoperability among systems, and there is a poor digital literacy and data science skill in people responsible of data within the hospital. So with this, we tried to create a new dictionary for new variables. So what we did in Orchestra, for example, we created more than 2,500 new definitions for common standard, but it's just a small piece on what should be done in this field. So what we learned from cohort study that if you have cohorts, they are very useful for producing evidence. And so we discussed longly with the European Commission how this can be applied to other infectious diseases emerging, like monkeypox, and in particular to the antimicrobial resistance. And one example on something we created that I think is very useful for the future and for the antimicrobial resistant field. So we have now in Europe, thanks to the European Commission, a trial coordination board that oversees all the clinical trial running in COVID-19 that is led by John Arne. The cohort coordination board led by myself, where we control and put together all the data from different cohorts in COVID-19, and then there is a vaccine network led by Oliver Corneli that try to summarize the most important trials together linking on vaccine. And this coordination mechanism, I think, should be duplicated also for antimicrobial resistance. Which are the urgent action that should be included as far as possible within national plan to contrast antimicrobial resistance? I think there is really a need of active real-time monitoring, not only of antimicrobial resistance, but also of hospital-acquired infection and antibiotic consumption. I would really love to see some government give mandatory audit and feedback for infection control and antimicrobial stewardship into the hospital, and compulsory educational programs in infection control and antibiotic prescribing in medical school and in specialties. I think this is the only way to create new different doctors. And we need a local calibrated guidance document in infection control and stewardship. My last point, how all of this can be integrated into national pandemic preparedness plan. We need a wake-up call. We need to understand that there is no pandemic preparedness plan without infection control and stewardship being core capabilities. We need to establish even more than surveillance. We need to go for automated surveillance for healthcare-associated infection and antibiotic consumption, really to fight resistance. And I think there is a very strong demand for reassessment of data sharing, system interoperability, and in particular to understand which is the link between privacy, individual privacy, and public health needs. We need multidisciplinarity within the team at country level taking care about preparedness plan, powerful and contextualized awareness campaign, and knowledge of the importance of the stewardship team and infection control in pandemic scenario. What happened during the pandemic, that the majority of the team, they were just moved to clinical care, and I do understand, obviously, we all did the same, but in preparedness plan, we should be very careful in avoiding that if we want to save antibiotics into the future. And I think we should discuss in maintaining how to maintain mechanism of perpetual infectious disease cohort to help the fight against resistance. There is insufficient research in effective infection control, in particular in vulnerable population, and we have seen that in COVID-19. We do not have enough information on implementation science, both for infection control and antibiotic policy, and we need to find a coordination mechanism for trials and for cohort at European level. I'm glad to take any question. As I said, I'm honored to be here today, and I will be glad to get also your question by email if you want to contact me later on. Thanks.
Many thanks, Professor Tacconelli, for your presentation, and particularly for pointing out the importance of combining and marrying antimicrobial stewardship with infection prevention control measurements. And with that, I'd like to open up the floor for discussion. There's different microphones in the room, so please approach them if you would like to take part in the discussion. And for the people online, we will be monitoring the questions and we'll including those in the panel. So we'll start. I don't see anybody approaching one of the microphones yet, so we'll start in the panel. Many thanks for your fantastic presentations. One common denominator you had was fear and also the problem of communication. How do we communicate and bring forward the role of rational antibiotic use? You showed it beautifully, Angadip, for India, but the other two speakers also, how, especially during the COVID-19 pandemic, in the beginning when we didn't know what was going on, how to deal with it. So what are the lessons you take from this? And if we would have a next pandemic coming without a focused treatment, what would you recommend? How should we communicate the physicians also with policymakers driving forward this need of doing something even if we can't always do something? Please. There's different microphones. Oh, you have the headsets on as well. Yes.
So one thing that I learned is that as scientists, we frequently don't think that it is our job to communicate with the public. We do think it is our job to communicate with policymakers. But what we don't understand is that communicating with the public also gives us probably much better leverage. So, and the other thing that I've learned from working with communities is that we frequently feel like people are not going to understand the complexity of medicine. I think that's a failure on our parts to communicate uncertainty appropriately and to keep communicating over time. I think people are willing to accept when you tell them, I know this much, I don't know these parts of what we are dealing with. So as long as we keep at it, I think we will be able to communicate better with communities and with policymakers. AMR is a whole different story, but the lesson that I would take from COVID for AMR is that we don't talk with practical solutions that can be implemented day in and day out. So I look at the UK example for how antibiotic resistance got brought down, how people were communicated with in doctors' offices saying, don't give your child antibiotics if they have a runny nose. We don't have that kind of communication. We don't have that consistent messaging, that building up of trust, that all will be well even if you don't use an antibiotic. So I do think we need to think differently about how we communicate.
Many thanks. There's always two sides to a coin. On the other hand, you don't have to convince people to get vaccinated, right? So I think you were alluding before to infodemics, and that is clearly one problem we have, convincing people to get the COVID-19 vaccine, but also many other vaccines. And I think that is a different side of the coin where you have come a far way in compared to us. You would like to respond to that?
Yes, perhaps from the COVID pandemic, what we learned. So there should be, as soon as possible, we're now talking about science, as soon as possible, in each and every country, there are scientists that are specialists in a particular area. And as soon as possible, these scientists should elude that there is a certain common ground. When it comes for a viral disease, for example, there are certain issues that are common knowledge to these scientists. And so a certain group of scientists, and there are various societies like ACMID, whatsoever, they should early on conclude on basics that they think are the ones that are important. And so you have to make, basically you have to find a majority of the scientific knowledge and bring this to the people. The second thing is, of course, when scientists bilaterally approach politicians, there should be consent that they don't lobby for their own particular interest here. Because then there is a diversity among scientists, which is a huge problem for these decision makers. And therefore, I think it's very important that there's a consent before the next crisis or whatever comes. How do you communicate in a particular area of science, a particular knowledge area? How do you bring a majority position out into the open? That's very important, because all those scientists are individuals that have their own stakes in a particular area. And I think in a crisis that is as big as that one has been, this should never have happened. And when it comes to antibiotic resistances, I guess, I mean, here are sitting so many experts, I guess 90% of the solutions, we are on the same level here. And this should be made clear, and therefore we have scientific societies.
Many thanks for those statements. I'll take the questions from the audience, please.
Thank you. Branwen Morgan from CSIRO, the National Science Agency in Australia. My question is to Professor Takanelli. You mentioned that you'd love to have real-time antimicrobial consumption data and love to see mandatory audit and feedback for antimicrobial stewardship in hospitals. It's something I've thought a lot about and would love to see as well. I think the challenge we have is that every hospital has a different caseload. We see seasonal variability in infection and drug-resistant data. And there's a huge nervousness around having that information made available, particularly if it was to be misinterpreted by media and the public about appropriate antibiotic use. Do you have any recommendations on how this could be done? Or alternatively, perhaps amongst your many coordination groups, perhaps you could come up with a framework or a dashboard that could be applied globally. Thank you.
So thank you for the question, and I'm glad that you share these points. I think that it's really time to think on a long term, and having real-time data on consumption would really make a huge difference. So I share all the perplexity you said. I know that's the major issue. And as I said, when we tried to connect, because in Orchestra, for example, we have also genetic data, we have immunologic data, serological, so we have a lot of data, and took almost 2 years just to have 15 different hospitals in different countries sharing data. So it was an immense amount of work. But then when we were able to see the final central data repository, everything was easy. So that gave us a lot of hope that it's possible to do it. And I think the solution is to have different boards working together, creating a framework that could be replicated. So I think that's the only possibility, that at the moment there is nothing like that. So I just pass this suggestion to the president of ESCMID because I think it would be very important that the society that has a very specific attention to antimicrobial resistance and usage of antibiotic, I think this is one step forward to take this action.
Many thanks for this comment and question. With that, I'll hand over and we'll be bearing those recommendations in mind. Please.
Yeah. Hi, my name is Mattias Larsson. I'm an associate professor at Karolinska Institutet in Stockholm, but I'm working in Vietnam, where I've been working for the last 26 years. So I did my PhD thesis many years ago, looked at antibiotic use in community, and then 75% of all kids had used antibiotic within 1 month. So it's a huge overuse of antibiotics, which we still see, and you can buy it everywhere in pharmacies. I'm working as a physician, pediatrician now, so I have patients coming into me, and most of them have used antibiotics before they come to me, and a lot of them think that's a problem, that they always get antibiotics prescribed if they go to a prescriber. That's one problem that we also see in India, the overuse and the availability of antibiotics. Then I've been working with a group that's here now, with Håkan Hamberger and Linus Olsson and Bent Jörgensen, in relation then to hospital-acquired infections. So we started a project many years ago, Vinares, where we did point prevalence surveillance in Vietnamese hospitals, and so a lot of hospital-acquired infections. So then we've been looking at specifically carbapenem-resistant Enterobacteriaceae, and we have been screening throughout the country. And in all hospitals that we have screened, more than 3,000 patients, we found that 52% are colonized with carbapenem-resistant Enterobacteriaceae. And also we have a high rate of hospital-acquired infections, like in neonatal units. The mortality rate is more than 50% if you have a hospital-acquired infection with carbapenem-resistant Enterobacteriaceae, Acinetobacter baumannii or Pseudomonas. So it's a huge problem in the healthcare system. Also, as a physician, I see, for example, urinary tract infections in children. Most are ESBL, and you can only use, for example, amikacin for a pyelonephritis. So there is ESBL has gone from hospitals out in community. What we also now see as a lot of patients that are discharged from hospitals, especially ICUs, 90% are colonized with CRE, carbapenem-resistant Enterobacteriaceae, that goes out in the community. So that's a problem, that there are upcoming community-acquired infections with carbapenem-resistant Enterobacteriaceae.
Many thanks for those comments. Maybe wrap it up.
The question is, this is a middle-income country, like we heard in India, and where we see then a pandemic of antibiotic resistance. And my question is, how can the European Union and European Union countries promote and work with low middle-income countries, where we now see a huge increase in antibiotic resistance?
Many thanks for that question. It's open to be addressed. A brief answer, if this is possible, to this long question.
Absolutely. And if you look at various political decisions over the last years, there has been, luckily, a growing interest in global health issues, which are driven very much by infectious disease crises, which is bad because it should have been already done before, but we should use basically this moment to increase these studies and this interaction and cooperations. And this is very important, absolutely.
So many thanks for the work you're doing and for following up on this. We'll keep in touch. Many thanks. There's a next question, please.
Yeah, hello. My name is Til Bachmann. I'm a professor for molecular diagnostics and infection at Edinburgh University. You mentioned, obviously this session is about COVID-19 and the learnings from that for AMR, and you mentioned vaccination as one cornerstone. But you also mentioned diagnostics, and I think diagnostics was obviously one of the key aspects why we were successful in the fight against COVID-19. Now with AMR, we still use antibiotics a lot empirically, and we don't use diagnostics to a full extent. So I would, and Lothar Wieler, you mentioned about the need for data, or data came up everywhere. So diagnostics could provide the data. Why are we not using more diagnostics in AMR, in the fight against AMR? What's your view? How could we enhance that?
You're actually opening up the question for the second panel. So in order not to scope the second panel, I'll ask you to wait with your questions for that. And we'll take the last question from the audience. If you don't get your question answered by the second panel, we'll follow up during the apéro. Thank you very much. Please.
Thank you so much for the opportunity. My name is Mohammed Suleiman. I'm a medical student. And my question relates to how can we as youth, as students, and as early career researchers, if we have an intervention or an initiative that seeks to address the epidemic of antimicrobial resistance, how do we stimulate interest on the part of the government, on the part of policy makers, because few of the initiatives that I'm involved in South Africa, there appears to be this resistance or this reluctance on the part of the decision makers to actually to assist in implementing these interventions for antimicrobial resistance. So how can we as youth stimulate that active interest on the part of the decision makers to actually ensure that these interventions, these initiatives are implemented on the ground? Thank you very much.
Many thanks. The floor is open.
To be very frank here, you see that I reflect to the example of climate crisis, climate change. Many scientists since decades have really clearly tackled this problem, have initiated this. From my understanding and from what I learned from people that work in this particular area, the robust demonstrations of young people in particular has really changed the scene. I mean, there are various scientists that did such a decent work since decades, but when these people then popped up the Fridays, I mean, there's a person that's living not too far from here who initiated this. This was a game changer, I have to say this. And I mean, it's the responsibility of the youth to rival here. It's very clear. So there are certain problems that need to be really taken up on the street. I'm totally convinced that the young people have to take this responsibility. It shouldn't be, of course, it should be in a way that demonstrations are done peacefully, but this is the way to do it. You have to stress the point.
Many thanks for bringing up this topic. Clearly, the future is the next generation. So before we will come to the second panel to address our colleague's question, we'll take the last question from the audience.
Yeah, thank you so much. I am Dr. Asma Naseem, and I am infectious disease consultant in Pakistan, the region where Dr. Nagadeep has come, and the lecture she delivered straightly, we relate to it 100%. The poverty, the overcrowdedness, lack of infection control, and then the vicious cycle of antibiotics diversion, everything. So my question is that since ESCMID is a global forum, and we have icing on the cake in South Asia, that we have metallo-beta-lactamase producer organisms, and the MBL and the New Delhi metallo-beta-lactamase, which is named unfortunately, from our region, we have no antibiotics for it, and no antibiotics in the pipeline, I think. And we are in a great double jeopardy in our centers, where if a multi-drug resistant organism comes, the patient just die because we just have colistin and nothing else. So can we just focus on antibiotic stewardship? Yes, but the development of this new antibiotics for MBLs. Thank you.
Many thanks for this question. Would somebody like to make a final comment from the panel, please?
Yeah. Well, thanks for that. And yes, we do have a problem with mortality when we have drug-resistant infections. It isn't just that there aren't the drugs. Sometimes there are the drugs and they are not drugs that people can afford in many of the hospitals we have. In terms of developing new antibiotics, I think there has been an emphasis on global partnerships to look at what can be done. It's still inadequate, but at least there is a start. And in countries in our region, I can certainly speak for India, there is an emphasis to look at what approaches can be taken to stimulate more research being undertaken to develop new antibiotics. The problems that we've had is that early stage discovery is fine, but then actually taking it to market becomes much more of a problem because of the regulatory processes and the amount of expense required to be able to conduct clinical trials.
Many thanks to the panel as well as to the audience for the fruitful discussion. And with that, I'll hand over to my co-chair.
Thank you very much. Thank you very much, Annalise. Thank you very much for an extremely interesting and high-level discussion that we've had this afternoon so far. There's more to come. But of course, it's not a competition between COVID and AMR. But having said that, the mortality, morbidity, and misery that AMR is and will cause in the long term is at least comparable to what we've faced with COVID over the 2 years of the pandemic. But ironically, the public perception of the two, if you want to call them pandemics, have been on the opposite side of the spectrum. So with COVID, we've had possibly an overload of information on and not necessarily the right information on social media, which has put a lot of pressure on politicians sometimes to take decisions not necessarily based on evidence, but based on what the public perception at that point was. And some of us health ministers had a very hard time sticking to the evidence and not pandering to what people were saying on social media. On the other hand, with antimicrobial resistance, there is absolutely or very little public perception at all, which is possibly as bad as having too much information and having too much public panic, if you like. And of course, the situation in different parts of the world, as we've heard in India and Vietnam, is different. And there are different priorities of how to tackle AMR best and easiest. And it can vary from sanitation, from hand washing, from access to antibiotics, from falsified antibiotics, from patterns of vaccination, which is why national action plans make sense, because national action plans address a global solution locally, so a global crisis locally. So the crisis is global, but the solution has to be local. And as we've heard, there are about 170 countries with national action plans, but very few of them are being implemented. So that is where globally we need to make the effort. We need to push for national action plans to be implemented, and we might need, we need a global fund to have implementation of national action plans taking place. And this is where we come back to public perception. How do you make politicians take the right decisions? How do you make politicians put money into a global fund? Well, there are some politicians who are enlightened and will do what is right, but most politicians find it easier to take decisions when there is a public public demand for it. So this is why we've asked for evidence. We've seen some of the evidence here. We need more of it. But the evidence needs to come out of this room, and it needs to come out of the clinic, of the bubble of microbiologists and clinical microbiologists and clinical infections and specialists, and it needs to go to the general public. It needs to be understandable by the general public, and it needs to motivate the general public, which in turn will motivate decision makers, which in turn will make national action plans implementable. So with that, I thank you. I thank our panelists. I thank my co-chair Annelies for this very useful session. And now we hand over to the next session and to our capable chairs, Sunita and Robert. And with that, I invite the next panel to come on stage with the new chairs. Thank you so much.
So welcome back, everyone. It's really my very great pleasure to welcome all of you here to Copenhagen for this meeting here. We will now start with the second panel. My name is Robert Skov. I am the President-elect and the Secretary General of ESCMID. And I will be joined here by Mrs. Sunita Narin, who is the Director General of the Center for Science and Environment in India, and also a member of the Global Leaders Group of AMR. So I will start by handing the word to Sunita, who will actually give a couple of introductory words to this panel here.
Thank you, Robert, and thank you again. I'm delighted to be with all of you. I think, Robert, from the first panel, what we heard very clearly is that COVID has created a huge momentum for three issues that were put on the table. One, the issue of public health. Very clearly, public health is on the table, not just health, but public health. The second issue that COVID very clearly has brought our attention to is the role of prevention. The question about washing hands, the question about building immunity, the question about preventing a disease. Clearly, that has more than ever before been put on the table. And the third, because I'm an environmentalist, for me, the biggest lesson from COVID really has been the learning that we have this terribly dystopian relationship with nature, that our relationship with nature really needs to be fixed. And that's really where the question of AMR, the question of innovation, the question of diagnostics has to fit in. For us, three major challenges. The first challenge, clearly a challenge where we have antimicrobial resistance and we need an agenda of conservation. We need to make sure that the antimicrobials critical for human beings are not used, overused, particularly in animal and in livestock, in the crop system, which is why we need more than ever a One Health approach. The second clear agenda is prevention. Now, this is where we need to go beyond what we have talked about till today. And we at GLG are very much putting this at the center of talking about not just about growth promoters and why they need to be stopped and to be not used, but also to look at the whole question about food systems. And Scott here will talk about that further, but it's very clear for us that the food and agriculture system has to be discussed, that we cannot talk about this only in terms of small ways of moving ahead, but changing the way we manufacture our food, changing what we grow and what we eat. This then links very much to the climate change issue, because we know food is at the center of climate change. We know biodiversity is at the center of what we grow, what is on our plate, what is in the wild. It is also about the barriers between human beings and animals. And that's really where many of these agendas are coming together. And for us, the issue of clean water, I mean, we know that the vaccine is important for rotavirus, but even more important is the provision of clean water and sanitation for all. And that's really at the core of the AMR challenge as we move ahead. So when we look at innovation, we look at diagnostics, the most important issue for us also is the challenge of affordability, because we have the issue of excess, but we also need to make sure that we have access provided for. And in all this, the modern surveillance systems, the diagnostics, not only have to move from human to animal, and both, but also make sure that they are accessible to large numbers of people. So it's an extraordinary challenge, but it's a challenge which I think the community of researchers, the community of clinical practitioners are most able to find solutions for. So that's really my introduction for this panel. Thank you, Robert. Thank you for the time.
Thank you very much, Sunita. I think these here really shows why we are here together today, really to make really the policy meeting the science here. And this actually make me have the pleasure to introduce our first speaker today, which is Professor Scott Weiss, who is a GLG member professor at the University of Guelph, and the director of for the Public Health and Zoonosis and Chief of Infection Control at Ontario Veterinary College. So please, Scott,
Great.
The floor is yours.
Great, thanks, Robert. And Sunita set the scene really nicely. So now we can talk about animals. A little bit different. I'm talking about diagnostics, but I'm not really the whole time. I want to talk about some of the issues and the complexities and the challenges that we have when we think about animals. And one of them is actually, what is an animal? These are all animals, and they're very different. We have intensively reared chickens in the top middle there. We have livestock out in pasture on the left. Different exposures to people, different exposures to the environment, different ways we interact with them, and we can manage them. Aquaculture, increasing dramatically. And it's going to be a very large component of human ingested animal protein in the future. And we don't really know how to handle a lot of things there. Diagnostically, therapeutically, they're still animals. We still treat them. They still get antimicrobials, often in the water and feed. Bottom right, we got a donkey. And you may not think about this, but donkeys are the tractors in some economies. Working animals get ignored completely. Top right, we've got chickens. This could be a backyard flock that's akin to a pet. This could be a small holding. We have a lot of small-scale agriculture that presents some challenges. And then the bottom middle, that's my kid and my dog. And the healthcare my dog gets is a lot more similar to the healthcare my child gets than any other animals. But the dog's still an animal. We lump everything together in animals. And that's not necessarily a good thing. So this will get talked about a lot probably at this Congress, the importance for new antimicrobials. And you can say 10 by 10, Chris mentioned a high-profile, high-impact drug every other year. And this is important. Obviously, we need antimicrobial development. So sometimes you say, okay, what do we need for animals? What's our target number of new antimicrobial classes for animals? And for me, it's actually 0. Even though I'm a user of antimicrobials in the animal side, we don't have many in the pipeline. We don't have new classes. Right? We need to preserve what we have. And new antimicrobials need to go into people, which means for the animal side, we have to figure out how to use what we have for as long as possible. And that's by using them less and using them better. And sometimes we just focus on less, and less isn't necessarily what we need to do. We need to use them better. We can drop the massive use, but make things worse. So we need to figure out how to properly use antimicrobials to reduce resistance, to improve the impact we have on animals. So the title of this was AMR Diagnostics, and I said I'm not really going to focus completely on diagnostics, and I'm not going to focus on AMR diagnostics in particular, because do we need AMR diagnostics? Well, kind of yes and no. AMR is the tip of the iceberg, the pointy bit in the top of the triangle, whatever you want to say. But AMR, is it the problem or is it the cause of the problem? It's a problem, is what we're dealing with. But we can't address AMR by addressing it directly. We have to address why AMR is there, and that's antimicrobial use. And that's itself not really the problem. Why do we use antimicrobials? Well, we use them because animals get sick, or they get reared where they might get sick, or because we're afraid not to use antimicrobials. There are a lot of medical, animal management, human behavior. The human brain is the biggest barrier to proper antibiotic use in most situations. So we need to think about this continuum. We need to address AMR, but we need to address AMU. And we need to address AMU by addressing animal health, animal management, veterinary care, human behavior, in a range of things. So we absolutely do need AMR diagnostics, and I don't mean to downplay that. We need the ability to characterize genes, to diagnose quickly, to implement rapid care. We need for surveillance, source attribution, research, and to a lesser degree, clinical management in animals. But if we really want to get the big picture, we need to reduce disease. And we need to reduce the use of antimicrobials. So our diagnostics really need to focus on things that will reduce disease or identify optimal treatments of routine diseases. Rule out bacterial disease. Again, confidence not treating is the biggest thing we could do probably in reducing antibiotic use in animals. Detecting disease, supporting decisions, all of these things will have a big impact on our use of antimicrobials, which will have an impact on AMR, even though we don't consider them AMR diagnostics. They're still helping us in this AMR pathway. And maybe to think of another challenge here is what Sunita mentioned at the start, access. So if we think you've got a sick cow, dog, cat, whatever it is, or a dead animal, what do we need to do to figure out what's going on and act? And act is the key part. Well, we need to recognize the need, so we need some expertise there. We need to have access to a good test, and often that's a diagnostic lab. We need to pick the test, requires some expertise, and expertise costs money. We need to collect an appropriate specimen, that costs money too. And again, it requires someone to think, figure out what to do. We need to ship it to a lab, takes time, costs money, interpret results, money keeps coming down the line, right? But we need the expertise to help do that. And then we have to have the tools to act. Both we have to have them available at all, and we have to have them available where they're needed, which is everywhere, not just in a rich country or in a specific niche market. So we need all these things to happen. And a large percentage of animals across the world that are raised, we don't have access to this for them. And a pretty impressive percentage of animals raised across the world don't have access to probably any of these, or maybe one or two in the system. I'm a veterinary internal medicine specialist. I work in a tertiary care hospital. We have lots of diagnostics. We have MRI, we have gene sequencing. That's not the reality in most of the world. When it comes to livestock, it's not the reality. When it comes to developing countries, where there's a lot of antimicrobial use, where there's a big burden of resistance, access is a big problem. So we need innovations, but we need innovations that will foster use changes, will foster improvement in what we do. So some examples, these aren't directly related to AMR, but they impact AMR. Rapid, easy, low cost, temperature stable, animal side pathogen tests, rapid tests. Let us differentiate bacterial versus viral diseases. Don't need to be very fancy, but if we could rule out a bacterial disease or rule in a viral disease to provide confidence that we don't need to use antimicrobials. And that confidence issue is a big component of this. These tests can give us rapid infection control, intervention, implementation opportunities, detect high consequence diseases, let us know what's going on for future prevention strategies to better use antimicrobials, vaccines, and other things, and help us apply evidence-based kind of therapeutic approaches. So these need to be easy, they need to be quick, they need to require not a lot of expertise, they need to be done on a farm without cold chain, they maybe need to be done on a boat, they need to be flexible. Other things, multiplex testing, quite commonly used in companion animals, not as much in our food animals. More bang for buck, better and a range of diagnostic tests, it's more efficient, it's more cost effective at times if they're developed right. We can identify emerging issues that might not be picked up otherwise if we're targeting a single pathogen. And we got good surveillance data to help inform for future activities. And as you know, the presence of an organism doesn't mean disease, right? We treat a lot of bacteria that aren't causing disease, whether that's asymptomatic bacteria in a person or in a dog, or whether it's a variety of commensals. So biomarkers, rapid animal side, ideally, biomarker tests that can help us determine when disease is actually present, not just an organism is present, and giving us confidence when not to treat. Something's there, but I'm not worrying about it. It's not bothering my patient, so it's not bothering me. It's a tough thing for people to do. And diagnostic tests that can help us overcome some of the barriers we have. And there are some barriers to vaccination, because if an animal has to be tested to see if it's been exposed to a disease, or it can't be raised, it can't be slaughtered, it can't be shipped somewhere, and we have a vaccine that can prevent that disease, but our tests can't differentiate vaccination immunity from natural immunity, we can't use that vaccine. There are regulatory barriers to using some vaccines because tests can't differentiate natural infection from vaccine immunity. So diagnostic tests that can let us use more effective vaccination strategies and remove some of these regulatory barriers. So a lot of this would apply to humans as well, right? A lot of this is fairly straightforward, rapid tests, easy in the hands of all the users, not centralized. So, we don't need to reinvent the wheel. We kind of do, and sometimes there aren't many human diagnostic tests being done on a boat, probably, right? But we've got a lot of things that are very similar. The concepts are there. The platforms that are being developed certainly can be cross-applied. But there are a lot of challenges, and money makes the world go round, and there's not as much of it going to the animal side, which is understandable, right? Human health is our priority, but there's a huge gap in funding at the public level, public sector level. In the private sector, there's a huge gap as well because, your average livestock species isn't worth that much money. There are huge cost, barriers for commercialization of products, as there are for vaccines and a variety of other things, lower financial return. And what we see in the animal side is often, okay, here's a new drug, or here's a new whatever, a new test. Let's try to figure out how we can use it in people. 5 years down the line, no, it's not very good. Let's see if we can use it in animals, right, as our backup plan because we couldn't make money in the human market. And, that's understandable, but we miss opportunities and we miss kind of speed because we don't do many things in parallel. We do a lot in series. And obviously the human work is more expensive, but paralleling some of these developments in animals can help speed access and maybe actually inform some of the human use. Field models in animals might actually be quite useful for some situations. It might be able to be advanced more quickly. But then we've got some other challenges here. We think about finance. Some livestock aren't worth very much. Your average chicken is not worth a lot of money. Your average dog, some people will spend a lot of money treating them. I'm one of those that's done that many times. But it's a challenge because the cost barriers are real. Tests, treatments, vaccines, they have to be economical if it's a food-producing animal, especially in the developing world. There's also the challenge of who benefits versus who pays when it comes to antimicrobial resistance. Because who benefits when we implement changes on a farm to reduce antibiotic use? More us than the farmer. They're taking a chance. Yes, they're saving some money in antibiotics maybe, but they're worried about their lifestyle. They're worried about the loss of their animals. But we're getting the benefit from it. And we have various examples of things that can be done to animals, but they cost money, and the farmer won't pay to do anything if it won't impact them. And the consumers don't want to pay more for the product, so effective prevention strategies get lost. Application, obviously, before, these need to be fairly simple if we want to get into new advances. We want things that don't need a lot of complex technical expertise. And that would be a huge improvement to animal diagnostics. Things that can work in the field, things that are temperature stable, especially in the developing world again. And there are logistical challenges too. Just as I mentioned, animals are really diverse. The animal markets are very diverse. Getting drugs, getting diagnostics, getting any products to the animal market is a big challenge. When the market's not very big at that individual species level in the country, it's harder for companies to put the time and the effort and the money into doing it, especially when there are regulatory barriers to that. Oops. So, think about this for a second. What would happen if we put rapid, easy, whole genome sequencing on every farm? A little plug-and-play system, you could sequence anything there. Would anything good happen? Maybe, maybe not, right? We might have a whole lot of data sitting on computers. Robert's shaking his head. We have a lot of data sitting on computers there, but if no one looks at it, we don't share the data, what does it mean? If no one acts on the data, what does it mean, right? Technology is great, and I'm not being anti-technology here, and I'm not being anti-diagnostic testing here, but we need everything else to go with it if it's going to be effective. So I'll use probably a really bad analogy here, but let's say the Titanic, right? So everyone knows what the Titanic sunk. So what if we had modern advances back then like satellites, 4K video broadcasting, right? We'd have really good pictures of this. Would it help? Well, maybe if they said, okay, there's a person there, send a boat there, bring in the resources, whatever, and let's look at what happened and let's prevent it from happening again, right? We use the technology. If all we do is have really pretty pictures of a boat going down, that doesn't help us. So it's how we use innovation. And I think the analogy does apply to AMR because we've got great tools to characterize AMR, resistance genes, genomics, but we have to use them. It's one thing to understand the genes that are there and the sequences that are there, but if that doesn't lead to action, what does it tell us besides, some interesting posters, some interesting papers? What's the action component? So diagnostic tests are great, but we need to have that corresponding, system set up to use them for decision support, veterinary support, the availability of preventive measures and alternatives, therapeutics in general, containment practices, and improved management. And we need to think about what innovation is. If we think about innovation in microbiology, innovation in medicine, everyone's thinking towards the left end of that, right? We've got new drugs, we've got new machines, we've got new tests, and these are great. They're really, really important. But innovation is also, in my world, the bottom right. It's not funky, and no one's going to put a lot of money into it, but barn design, how we raise animals. That's probably one of the biggest things we could do to reduce antibiotic use is raise animals better. Ventilation, feed, things like that, new drugs. Social media, cell phones are changing the world, obviously. Apps, we've got a prescribing app at our facility that's used, it's open access internationally. The one on the right there is a tick app from Canada. You take a picture of a tick, AI figures out what tick it is. It tells you what tick it is, surveillance data, and it also tells you some of the disease concerns. And the human factor, whether that's someone that's an allied animal health professional filling in gaps in a developing country, whether that's a veterinarian in a higher income country, it doesn't really matter. But all these things are key for these technologies and these innovations to actually have an impact. So, I've probably said this too many times so far, but we need innovation. We need access to rapid tests. We need access to things that will help us differentiate disease from colonization, to give people the confidence to act, and oftentimes give people the ability to do what they really know they should do, but they just don't want to because they're afraid to do it. But at the same time, we need to make sure that those innovations are a part of a system. So they're including health systems, including communications, management, and everything else to help us take that knowledge to good action. Thank you.
Thanks a lot. So our next speaker will take us a bit into the human part of it. It's going to be Professor Sharon Peacock, who is a professor of public health and microbiology in the Department of Medicine at the University of Cambridge, as well as being the executive director and chair for the COVID-19 Genomics UK initiative or consortium. So please, Sharon.
Thank you. It's a privilege to be here, and as I've listened to the previous talks, what really strikes me is how my talk interweaves with everybody else's, which is probably a good sign as you stand up and start to talk to the audience, so I'll be able to draw on what other people have said up until now. Now, thinking about my title, I'm really looking at diagnostic innovation to improve patient outcomes. That's what I really care about. And from global infectious diseases. And that includes AMR, but it's not just about AMR. And I think that picks up with what we've just heard from Scott, which is about the fact that AMR is not an island. We have to take it in the context of the broader infectious diseases piece. And I wrote down from his talk, myriad parallel health systems. So we need to consider this very holistically. So what I've done here is I've started with first principles of how to define areas for diagnostic innovation to improve global outcomes for infectious diseases, including AMR infection. And I've got 4 things that I've considered here. First are, what are the leading causes of infection death? Second is, what are when are diagnostic tests actually recommended for use? The third and the fourth go together, and that is, when are current tests suboptimal, and when could new tests improve human health? Now, in order to consider these really first principles, I've gone to data and evidence from the World Health Organization, which I'll be talking about now. So let's start with what are the leading causes of infection death. And these graphs I show you will be very familiar to you, but I hope to put a somewhat new twist on them as well. So this is a graph from the fact sheet in December 2020 from the World Health Organization of the top 10 causes of death globally overall. And what you'll see here in green is that communicable diseases are in the green, and there's a difference in dates. So there's a measure in the year 2000 in the open circles, and then a measure in 2019 in the closed circles. So this will be very familiar to you, that ischemic heart disease and stroke are the 2 leading causes of death globally, and that deaths are increasing over time from that. What you'll also be aware of is that lower respiratory infections, neonatal conditions, and diarrheal diseases are also in that list. However, there's a really stark contrast when you compare leading cause of death in high-income countries and those in low-income countries. So on the left, you have deaths in high-income countries, and you'll see that one infectious disease syndrome, lower respiratory infections, appear there, whereas on the right you'll see 6 different conditions, including, very importantly, neonatal conditions right at the top of that list, and I'll come on to that in my next slide, but also lower respiratory infections, diarrheal diseases, malaria, HIV and TB. Now, we've heard today how we've compared AMR to specific conditions such as HIV, but actually what I would say is there's a different way of looking at it, and that is that AMR cuts right the way across all of these other diseases. And so the burden from AMR is likely to be vast and undermeasured. So we've looked at the leading causes of infection, which are 3 syndromes, and TB, HIV, and malaria. I've already said that there's a very high burden of AMR for all of those conditions, but what I'd like to do next is pick up on neonatal infections, because this is something we need to be talking about as a community. Now, this is a very big table put together by Phoebe Williams in a paper published in the Bulletin of the World Health Organization in 2022. And what she did here was gathered the recent large-scale multi-center observational studies of neonatal sepsis. It's such a big table, I'd like to focus on 2 studies. The first is in Bangladesh, India, and Pakistan. This is a very large study where the investigators went to the homes of more than 63,000 infants. They visited them up to 10 times between the ages of 0 and 59 days. They were looking for signs of sepsis, and when they saw them, they took a blood culture. From that, they knew that the minimum incidence of culture-positive sepsis was 2.7%. And if you work your way across that row, you'll see the causes, and E. coli and Klebsiella are top of the list. Now, worryingly, 25% of the 50 tested pathogenic gram-negative isolates were not susceptible to penicillin, ampicillin, or gentamicin. So if we turn to the second study by Sands et al. In the Barnard's network, they went to 12 urban hospitals. And again, this was a large study where they recruited more than 36,000 infants, neonates, I would say, in the perinatal period, and then followed them for signs of sepsis and took blood cultures on those who had signs and symptoms. Nearly 7% of children, neonates, had culture-positive sepsis, and you'll see the causes there. Again, we've heard Klebsiella, Serratia, E. coli are important causes of sepsis, and this is where it starts to get extremely worrying. Of the 885 gram-negative pathogens, there were very high levels of resistance to ampicillin, cefotaxime, ceftriaxone, meropenem, and tigecycline. So when we talk about AMR, I think we have to drill down to specific diseases and think about how we're going to tackle them. Moving on then to the second point, when are diagnostic tests actually recommended? For this, I've turned to 2 pieces of evidence, 2 very helpful guidelines from the WHO. The first is a tremendously helpful WHO Aware Antibiotic book, which is a management of infection book, and specifically focused, in addition, around the access, watch, and reserve antibiotics. Now, this gives evidence-based guidance on antibiotic dose, route, and duration for 34 common clinical infections in children and adults in both primary healthcare and hospitals, and it complements other WHO publications, including the list of essential medicines. Now, when you look at this book, it's in 3 sections. The first is care of infections in the community, the second in hospitals, and the third discusses reserve antibiotics. Now, I'm questioning here what tests should we be doing in patients in primary health. And what I've done here is written down where this book says a diagnostic test should be done. And you can see the list there, including pneumonia, suspected TB, sexually transmitted infections, symptomatic urinary infection, group A strep throat infection, etc. Now, against the red stars, you'll see that actually many of those conditions actually have a high risk of AMR. Now, if we move on to the hospital facility, all of the conditions that are listed in this book require a blood culture. And most of those will be linked, or nearly all of them will be linked with an issue of antimicrobial resistance. The final bit of the book, which is relevant when I come on a little later to talk about diagnostic tests, is when to use reserve antibiotics and how to use them. These are last resort for selected cases of confirmed or suspected infection with multi-drug resistant pathogens. We can also find very useful guidance on what tests to perform from the WHO Essentials test. This points out that in the community, without labs, you're dependent on point-of-care tests. And in healthcare facilities, culture underpins what we need to do to investigate patients, together with serology, and molecular tests and immunology for viral infections, for example, and STDs. Here's the crunch. I've shown you what causes deaths, and I've shown you what tests we actually need to use to really sort out what patient needs antibiotics and which one. But there's a problem. There's a lack of utilization of tests that actually work at the moment, let alone devising new tests. Many diagnostic tests are already available, but they're not used, or they're not used effectively to guide antibiotic use. And I would put blood culture and susceptibility testing right at the top of that. Even in places where blood cultures are available, they're not necessarily used to the extent that they could be. In addition, we know that there's a lack of sustainable lab capacity, funding and training to get microbiology capacity across the world. So the first question I would pose is, how can diagnostic innovation be directed to improve uptake of existing tests, which would then inform personalized prescribing, which is what we're doing when we ask if the patient has an AMR infection or not, and improve antibiotic use and stewardship. The next gap I would highlight, which really reflects what others have said, is the importance of surveillance. Now, coming back to the WHO Essential Test List, it talks about point-of-care tests in the community, but actually the truth is that most prescribing happens in the community without any diagnostic tests having happened at all. And that is based on surveillance data. What you give that patient is based on surveillance in your area. The same is true in hospitals. Prescribing in hospitals for bacterial infections, it depends on surveillance data combined with a variable amount of testing depending on availability. So my next question is, how can innovation create stronger diagnostic surveillance networks for empiric prescribing and better patient outcome from all infection, including AMR infection? So when are current tests suboptimal? Well, the first point of this is when they're not available to direct antimicrobial prescribing, so a lack of current tests in a setting. They're also suboptimal when they're not performed correctly, or the test itself is suboptimal and doesn't perform correctly, and that will lead to suboptimal prescribing. But the third circumstance when tests are suboptimal is when they're performed but the data is not used again to inform empiric prescribing in that population. So my final two slides really talk about where I think innovation should be focused. And the first is on focused on appropriate prescribing through stronger diagnostic systems. And Scott, this really does come back to what you were saying about the animal system. And what I say here is strongly drawn on the strategy document from FIND. My first is that we really need to strengthen diagnostic ecosystems in the community where most antibiotics are used. For example, point-of-care tests. The second is to strengthen diagnostic ecosystems in hospitals, introducing the tests we already have, and improving diagnostic systems to reduce death from severe infections, including neonatal infection. The third is to empower on-the-ground diagnostic surveillance to improve our empirical prescribing and use of local data, and that could be through digital tools, etc. My fourth is we know that we have a reserve antibiotic list which is running low. So we need to think about the ease of accuracy of susceptibility testing for those drugs. And finally, it'd be remiss of me not to mention focus on TB to find the missing millions of cases. We also need to innovate to focus on local empowerment of test manufacture. So bringing local innovation in diagnostic test manufacture at scale in the country it will be used in is likely to mean that it will become sustainable and affordable for local markets. Linked with this is what FIND calls taming the Wild West. There are many diagnostic tests in use which are substandard and poor quality and need to be removed from the system. So for me, the summary highlights for diagnostic innovation are these 4 points. That we must strengthen the diagnostic ecosystem in the community, strengthen diagnostic test utilization and data networks in hospitals, innovate on the ground surveillance and use data for input prescribing, and finally, innovate in local test manufacture to provide affordable, high-quality tests. Thank you for listening.
Thanks a lot, Sharon. And I think your talk leads directly to our last talk in this session here, which will be done by Professor Mark Bonten from the Department of Epidemiology at University Medical Center in Utrecht in the Netherlands. So please, Mark.
So what I was trying and what I was planning to show to you is that in this field we deal with conventional wisdom. And the conventional wisdom is that antibiotics select for resistance. You can't argue with that. Not giving antibiotics does not select for resistance. Almost always true. And we feel that if we give targeted antibiotics directed to the pathogen that causes the disease at hand, that then you will select less for antibiotic resistance than you would just give blind, broad coverage antibiotics. There's not so much scientific evidence to prove that, but that's what we want to believe, and therefore we preach that. The fourth point of the conventional wisdom is that antibiotics do more than causing resistance. They also kill bacteria and thus save lives. And the physician that prescribes the antibiotic has the responsibility for the patient in front of her or him first. So if the physician thinks it is needed to prescribe antibiotics, the physician will do that, and later at night after dinner, she or he will think, I should not prescribe so many antibiotics for the society. But the first part is to treat the patient well. And we all know that in acute infectious diseases, most of the treatments are empirical. Empirical meant long time ago based on evidence, but here empirical means not based on evidence, based on epidemiology and based on what we think, or the physician thinks at that time point is needed. Now this is where diagnostics could help us. And you could think of 30 years ago, for each surgeon, it was fully acceptable that 20% of the times that he operated a patient for presumed appendicitis, it was appendix sana. So there was no inflammation, but that was good. Well, that has been changed because of diagnostics. Now we have an echo or a CT scan, and that incidence has dropped dramatically. Ironically, antibiotics have helped as well, so not all patients need surgery anymore because of antibiotics. Now, the O'Neill report was in 2015, and I had several slides of it because the O'Neill report already stipulated that the appropriate use of rapid diagnostics is fundamental in controlling unnecessary antibiotic use and thereby preventing antibiotic resistance. And it was estimated that in the United States, per year, 27 million people were exposed to unnecessary antibiotics that could have been prevented with rapid diagnostic tests. There was no reference of a study where it came from, but that's also what we think that happens, that many patients are prescribed unnecessary antibiotics. And I would focus on two fields here. One is community-acquired infections, respiratory tract infections, and one was urinary tract infections. So what needs to happen is that a patient, when seen by a doctor, either goes to empiric treatment, which is usually much too broad and often unnecessary, or that there is that rapid diagnostic test and everything goes well, there is targeted treatment, and many patients will not be treated because, for example, in respiratory tract infection, they will have a viral infection that doesn't need treatment with antibiotics. Now, If you look at a very important patient domain, which are patients with acute respiratory tract infection that are admitted or seen at a healthcare facility, in an emergency room, in a hospital, the patients are apparently sick, otherwise they were not there. Now, what do the data show us that rapid diagnostic testing can do in that setting? There's not that much good data, because it's very difficult to do such a study. I had one example of a study done in Southampton, I think it was in the United Kingdom. It was a study in which about 500 patients were randomized, either the standard approach or we used a rapid diagnostic test. The test was done in 100% in the intervention group, and apparently in 45%, that was the standard of care, in the other group. Much more viruses were demonstrated or documented in the intervention group, 30% more, absolute 30% more than in the other group, but the amount of antibiotics was exactly the same in the two populations. And that's what we have seen frequently, that you may be able to have a better diagnosis, but that does not translate one-to-one in less antibiotics. Because the prescription is in the head of the physicians, and it's the combination of diagnostic stewardship to antibiotic stewardship. And the test result needs to be weighted, needs to be taken into the decision-making, whether yes or no to prescribe antibiotics and what antibiotics. The easiest way to reduce antibiotic use is not prescribe antibiotics. And many studies in the field of antibiotic stewardship were small studies that looked, can we reduce antibiotics? Yes, we can. Very easy. Don't prescribe them. But that's not safe. If you do antibiotic stewardship studies, including the studies with diagnostic stewardship, safety comes first. So you must be able to demonstrate that the intervention that you do is safe for your patients. So there is a superiority to be studied. Do you do a better job in antibiotic prescription, less unnecessary antibiotic use? That's one part of the deal. The other part is, and still demonstrate that you're not harming patients, so that the outcome of the patients is comparable. And you could look at 30-day mortality or 90-day mortality. We looked at 90-day mortality in that same population. And we had an implementation of antibiotic stewardship in 9 hospitals in a step wedge design. It was very time-consuming, and actually what we did, we was telling the physicians in these hospitals repeatedly, prescribe antibiotics in line with the guideline. For this indication, it means penicillin, amoxicillin, or doxycycline. And try to reduce your amoxicillin clef, cephalosporin, and fluoroquinolone use in this patient population. We repeatedly conveyed that message to the physicians, to the residents that were prescribing the antibiotics, and we told them then, either you're doing a very good job, keep on doing this, or the other hospitals do much better than you do, come on, do better. So that was the intervention. And in doing so, we could demonstrate that that intervention improved the use of what we call the narrow-spectrum antibiotics versus the broad-spectrum antibiotics by 27%. The overall antibiotic use was the same. But there was much more narrow-spectrum antibiotic use, and day 90 mortality in this study of 4,000 patients was non-inferior. So we really showed safety of that intervention. Whether this is a sustainable intervention that will prolong after we stop the study, we don't know. But it takes a lot of effort to make a small change. There was a recent publication, which was an international study that looked at a different population, elderly with urinary tract infections, elderly seen by the GP or in elderly care homes. And there was a similar intervention package, also with diagnostics, but not on a pathogen level. And they were able to show that they could reduce in that study in 4 countries the antibiotic use with about 40%, and also demonstrate that that was safe for the patients. So my take-home message was a very nice slide. Was that yes, rapid diagnostics can make a difference, but only in combination with antibiotic stewardship. And the two should never be seen and never be studied separately from each other, because you could demonstrate a good diagnostic test, but if it's not used appropriately, it's still not a very good test for the patients. And we really need scientific breakthroughs in rapid diagnostics, but also in understanding, and that has become very apparent during the pandemic, in our behavioral science. How can we convince all the physicians in the world, and it may start with the students, how can we convince that we should reduce antibiotics there where it's not needed, and how can we create that environment that we get these antibiotics, these diagnostics, at the place where it is needed. Now, my experience is in Western Europe, and we are, compared to the rest of the world, spoiled and rich. We can put all these apparatus in our hospitals, and we can use and misuse them. But don't underestimate the complexity of building in rapid diagnostics in the daily life of prescribing antibiotics in acute infections. So there we really need scientific breakthroughs in the way that we can distinguish the patients that need antibiotics and that do not need antibiotics. And I'm in this business, or in this research field, for 25 years now. And when I started, I already heard, we will have soon a test that will give us that answer. I hope I will see that test before I retire and no longer forget to upload the correct version of a talk. Thank you.
Thank you, Mark. I think that was an excellent memory of your slides. I have seen your slides, and they were very good, well represented here. So now we will open up the floor, and I know we are guilty from one question from the last session. So Till, I don't know if you still want to put that one. And while Till is getting to the microphone, I really would like to urge the rest of you to go up to the microphone. Please state your name and your affiliation and your question. The panel discussion will only get really good if we get some good questions from you guys. So please, Till.
Thank you very much, Robert. And I really must congratulate and commend the organizers. This was a fantastic session on diagnostics, and it really addressed so many questions and aspects. And it's really what we need. We need to raise the profile of diagnostics so it's up in everybody's mind that it is a useful tool in the veterinary sector, and I specifically like that this was present here as well. And Mark, you made the twist or took it on with COVID and with the pandemic, and I would like to come back to this because with COVID, what we had at the end, mainly we saw lateral flow tests being used. And we know about the performance of lateral flow tests, and we know about other technologies which are out there. And as you said, with AMR, we have a big panel of diagnostic test technologies which we could use, but we don't. So I put back the question to the panel. What do you think is actually, where's the difference? What can we do? Where's the difference between COVID, what we have learned there, what we have seen there? There was a huge uptake of diagnostics. In AMR, it isn't. What can we do about it?
I will give that to you, Sharon.
I'll start. Is my microphone okay? Yeah. I'll start. I'm sure others will want to come in. What I immediately think of with your excellent question is behavior, social behavior. Because people, they had to do a test at home, really, to then adapt their own behavior. For example, if they were positive or negative. Throughout the pandemic, knowing if you were positive or negative dictated what you then did. I wonder how the public would grasp the question of other infectious diseases and antimicrobial resistance embedded into that. And so unless it has a really clear impact and positive gain for the individual, then I think it'd be quite difficult to get the level of uptake that we saw with the COVID-19 lateral flow tests. And that was a really interesting example. But even now, people can go and buy a lateral test that obviously you need the money to do that. They're not overly expensive. People are not inclined to do that now because there's no incentive at the end of it. So I think individual behaviour and sociology is really critical to thinking that we might do that for AMR.
And can I ask you, Scott, do you have an animal kind of perspective on that?
Answer? Actually, very similar. Motivation is really the big thing, right? Because with COVID, you're motivated. You want to know because you want to do some activities. One of the problems we have with antibiotic use, and I don't think it's just in animals, it's everywhere, is we do a lot of it culturally. And culturally, I mean, this farmer does it because his dad did it. Who did it because his dad did it? Not because they should, because they don't want to change. And if you're not motivated to change and you're not motivated to act, why would you be motivated to test, especially if that test costs time? So it's that educational component, I think, that really needs to feed into uptake of a lot of these things.
So thank you very much. Till, I'm not sure you get the whole answer of this, but so thank you very much for taking it up.
So many questions.
Yeah. So,
Hi, Cesar Arias, Houston, Texas, Bogota, Colombia. I'm professor of medicine at Weill Cornell. Mark, you did a phenomenal job without the slides. I think I've seen you even better that when you have a slide, so fantastic job. My question is relating to behavior. As an infectious disease physician, for me, it's almost impossible to convince a surgeon or an oncologist with a neutropenic patient, a bone marrow patient, even with the best tests available, to stop the antibiotics. And the reason is because they see their patient as their responsibility, and this is my responsibility of the patient. As an infectious diseases, we go, we do recommendation, but it's hard sometimes to own that responsibility. So those behavioral changes, particularly in those specialties which are the heaviest of all to use antibiotic, is very difficult for stewardship manners and all that. And we had several strategies to do that, but I will be very interested from your point of view, Mark, and others, how do you approach that behavioral change in those specialties and surgeons, transplant surgeons, for example, where that situation is very complicated?
Yes, I recognize the setting. That's the hospital-based setting with the very severely ill patients. That's a very, very small portion of the total antibiotic use. And if we would quantify or would be able to quantify the total selective pressure created by antibiotics, then probably the ICU and the hematology wards would be very small parts of that. So that I would still try to convince them to stop antibiotics or to, instead of give 5 antibiotics, maybe 1 or 2 is enough. But if you look at the population level, then I think there is more to be gained in the prescription in the population. And there we also have challenges. So maybe the home tests that have now become, let's say, well known to everyone can help for people not to go to the GP if they don't feel well, if they see, oh, it's flu, it's RSV or something else, whatever we can put on the test, I just need to wait a few days. For the physicians as well, it's easier for a GP to prescribe an antibiotics course than to take 20 minutes to explain why not. Because there's also a demand from patients, and that's also something that we can work on to see, can we change that expectation by better informing the public on the consequences of antibiotics. I think there have been good examples of that can make a difference, but that's, I think, ways to explore further. And still, in the hospitals, and especially in those patient populations that you mentioned, I think there's not that much we can do there. Although I may be cursed for saying so, but...
Thanks a lot, Mark. Yeah. Scott, you had a comment too?
Yeah, quick question for the audience. How many social scientists are out there? That's a problem, right? We've got one hand, 2 hands maybe up there. There should be much more engagement because that's the issue, right? And there's differential blame. So I battle with our surgeons. So you don't need to use antibiotics in this case, right? You know you don't need them, yeah. Are you going to use them? Yeah. Why? Because if the animal gets an infection, I'm going to think that's my fault, even if the antibiotic wouldn't have helped. If the animal gets an adverse response to the drug, well, that's the drug's fault. That's the drug company's fault. Resistance, oh, that's your fault because you're supposed to fix that, right? We have differential responses to things, and that guides a lot of our behaviors.
Thank you. Emmanuel, and then we go back here.
I'm Emmanuelle Campo. I'm a clinical microbiologist in Paris, France, and I'm also a member of the executive committee of ESCMID. Many thanks for your brilliant talks. And I have a question, because you say that infectious disease, are not so important in the lethality compared maybe to stroke or ischemic heart disease. And also we know that antibiotics are cheap now. So how to convince the hospital directors, the Ministry of Health, that infectious diseases and clinical microbiology is looking after these diagnostics are important, and it's worthwhile to invest in them and to educate them, and of course to have them in all the places. What will you say?
I'll start with that. I wouldn't say that, those kind of tables, they do rank diseases, ischemic heart disease, stroke, etc., in rank order. But I wouldn't like to say that they were kind of more important, because there are other metrics that underpin importance. For example, many infectious diseases occur in people at the beginning, the middle of their lives. Infection in a woman in pregnancy, or infection in a neonate. So when you're thinking about importance, those graphs are very crude because they show the absolute numbers of death. What they don't really reflect is the lost lives, the lost opportunity for that individual, the lost opportunity for their community if they were to have survived. So infectious diseases are often inherently treatable and reversible. And the thing that attracted me to going into infectious diseases is that it crosses all of the ages, but people are often restored to full health afterwards. And so I would say this, but I think infectious diseases are really crucial because they do have that reversible element. And you actually need a short course of treatment for patients. And so one downside of trying to fund new antibiotic development is you might need a week or 2 weeks of antibiotics. But from the patient's perspective, actually having a short course rather than years of treatment is very positive. So I think it's a somewhat artificial construct to compare one thing against another. And the reason I'm here today is because I do think infectious diseases are incredibly important. Thank you.
Thanks a lot. Fred?
Okay, Frédéric Laurent, I come from France. I'm a clinical microbiologist, and it's a question for Jeffrey, because you told us that there is a less interest for antimicrobial innovations for animals in your talk, and I'm not so optimistic, because in fact, the regulator is more severe for humans than for animals, and many of the innovation in terms of antimicrobials, it's more easy for a company to have an access of the market for animals than for human. And some company have in mind to start with animal before human. For example, I work on phage therapy, and many companies have in mind to start with animals. And I would like to know what is your feeling about that, and the way to regulate a lot this point.
Well, I think it's a challenge. The regulatory side goes both ways, and I think Sharon mentioned this too. There are a lot of really bad tests out there because the regulatory barrier is very low. At the same time, in the animal world, we have barriers to using tests that could be useful. So I'll give you an example with avian flu. There's a rapid test available in the US for poultry, and I've wanted to get that in Canada dealing with bird rehabilitation facilities. Because if you bring a bird in there and that bird has avian flu, all the other birds may die, or all the other birds may be killed. And the barrier we've had is the government doesn't let us bring this test in because it's not the gold standard test. And it's being used, we could use that or we could do nothing. And that's a barrier that comes in. So I think it does work both ways. Certainly we need to have better scrutiny of tests so that they are accurate and they're actionable. We need to have better ability to get appropriate tests in. And it's a challenge, I think, we find in part of it's development of the tests and licensing, part of it is access too. So if you're a company, where are you going to go with your tests first? You're going to go to places where there's a lot of money and a lot of animals. You're going to focus on big markets and species with big markets. Smaller species, less common species that are less valuable, and smaller markets don't get that same. So really answering your question, but I think certainly there is some development that goes primarily in the animals, but I think we're looking at new platforms and new technologies. I think a lot of that's going to come from the human side.
My question was more about drugs, not for tests, but for drugs.
About drugs?
About drugs, because it's more simple, for example, for fish therapy. Many companies have in mind to go to the market for animals, to treat animals, and not for human, because it's more simple to have an access of the market. Just for drugs, not for tests.
Yeah, for drugs, this is a big area, I guess, too. I'm trying to spend an hour talking about it. For drugs, yes, it's easier to get things licensed. There's less economic incentive a lot of times to do it. From antimicrobials, we're not looking at new antimicrobial classes for animals, probably. We're looking at new formulations of antimicrobials, and that's fine. New formulations. Sometimes we have drugs that are out there because we've got a need. Sometimes we have drugs that are out there because someone's trying to figure out how to use a drug that's off patent. So I'm not sure there's really a simple answer to that, but yes, you can develop some things easier in animals because you have less regulatory hurdles. It's a lot cheaper to get that done. But then you run into the problem of having to be able to use them and make money using them.
Okay, thank you very much. And the next.
I'm Dr. Faisal Hanif, and I'm a clinical microbiologist and Secretary Medical Microbiology and Infectious Disease Society of Pakistan. So currently we are in the era of stewardship, start from the IPC stewardship, and then there is the antimicrobial stewardship, and now the diagnostic stewardship. So my question is actually related to the antibiotic timeout from the Mark, from you, the question is from you, that for the antibiotic timeout, we generally use the diagnostic stewardship. So two types of stewardship generally we are using. One is the culture-based diagnostic stewardship for the rapid test, and the second is the non-culture-based diagnostic stewardship for the rapid tests. So what do you think? Because the price for both type of test, there is a quite high difference. Because if you are doing the culture-based, the price certainly goes quite high, and if you are doing the non-culture-based, the price goes down. So what do you recommend to start up? Where should we go?
Not sure if I understood the question completely, but I think the culture-based approach for diagnostics is by definition not rapid. And therefore, I think the highest likelihood of really changing practice is with rapid diagnostics. But still, the rapid diagnostics that we have now may not be rapid enough to really change it, because it still needs, in many instances, a lab facility. Samples need to go through the hospital and then go to the lab, and then the result comes back. Usually that goes fast, but still we need a scientific breakthrough that we really get tests that tell us what we need to know next to the patient. And still we don't have those tests, at least not from, let's say, that tells us from an etiological perspective what the pathogen is. Yes. We have some proxy tests that can help us to distinguish maybe between a viral cause and a bacterial cause, but still these are not good enough to base decisions on for most patients.
Actually, for the culture-based, I'm talking of the SeptiFast, SeptiCheck, and the BioFire systems, because these are the systems which are rapidly going in our diagnostics. So
yes, so the points I made apply also to these tests.
Thank you.
So now we take Kitty, and then here, and then there.
Thank you, Robert. I'm working with the AMR division in WHO headquarters. I have a statement and a question. The question is on the diagnostic, but I would like to make the statement first. I think everything I've heard this evening is about the interdependency between the different interventions. And this is exactly what we are doing. Countries are still moving in a fragmented manner. Focus on stewardship, focus on surveillance, focus on this. There's no comprehensive programmatic approach. As we see it, there are 6 building blocks. First building block, political commitment. That comes with the funding, with the education, with the regulations, with ABCDE. Then, second building block, access to early quality assured lab, because a lot of the laboratories, if available, are not quality assured at all. Third, access to appropriate treatment, not just treatment, appropriate treatment. Fourth, infection prevention and control, the whole prevention, vaccinations. Fifth, supply chain management. Uninterrupted supply chains. You can have all the labs in the world and doctors knowing what to do, but if the supply chains are not there, major issue when it comes to the lab in many, many countries. And last but not least, sixth building block is strategic information, which comes together on AMR surveillance, antimicrobial consumption surveillance, and research. This together should be the approach. And we have to look at, of course, setting specific, how you organizing, what you prioritize, but we need that analysis. What I also heard is about behavior, the patient perspective and the provider perspective. This is why we are developing, finalizing a people-centered framework for AMR control to guide that. And this will be also presented. My question on the diagnostics is, I've worked in TB control for almost 40 years. I hear the same thing now about AMR. It's too expensive. This is the answer I get. When we talk about innovation, we are setting up a global AMR, diagnostic initiative. One of the building blocks there is innovation, introduction of new tools. And what you hear is the same I heard when we got the GeneXpert, LPA, it's too expensive. I think what we need to do when we introduce new diagnostic, we start immediately doing cost effectiveness analysis. What is the cost of not using them? And I think that needs to go hand in hand. So I would like to, because I'm concerned about low and middle income countries. So I would like to know how is the panel thinking about innovation, really laboratory innovation in low and middle income countries. Thank you.
Yeah. Sharon, please.
I will start. Thank you. Well, first of all, that sixth building block sounds absolutely marvellous, and that should be the Council of Perfection. Many countries are not even close to that. So the question is how you get there, and there has to be a process of building blocks. So, for example, when the Fleming Fund was first set up in the UK, it would actually grade a kind of a laboratory as to its capabilities. And so rather than saying you have to get to the six straight away, perhaps we can speak offline about how you deal with the building. So you need all of those. And that was really what I was saying it's the diagnostic ecosystem. It's the whole system. I also really like what you said about putting patients at the center. That's absolutely right, because it's the patient that we need to think about. TB, I don't think I can disagree with you on that either. We do need to be finding the missing millions of cases. And it's a question of who says it's too expensive. But TB is extremely complex problem, and other people might be more suited to talk about that. But I agree that that diagnostic innovation, if I was going to put diagnostic innovation anywhere, and you saw on my slide, I had to mention TB as a diagnostic area.
So I think I was misunderstood. What I mean to say is that thanks to the Global Fund, who spent $55 billion on 3 diseases over the last 20 years, we have introduced GeneXpert worldwide. Without that, we wouldn't have any MDR-TB diagnosis and treatment. Same for LPA. With the funding came also the research and the proof that it, in fact, was a cost-effective intervention. What I'm trying to say is that with all that money for TB and HIV, they got the ELISAs out everywhere. We need to make the same case for bacterial and fungal diagnosis, because there is not much about a bacterial diagnosis. Thank you.
Thank you. I just say that there is coming up a good line, which is very good, but we also have to respect time. So I will say that there is no more room for the line. Those of you who are in line, that's okay, but we will only be able to do those. So Tina?
Yeah. My name
and short, please, from now on.
Okay, my name is Tina Jansen. I work for WHO on AMR. seconded by ICARS. I wanted to revert to the behavior, because human behavior has been mentioned so many times, and get your advice at the end of my question. I've just been the focal point for a quadripartite project developing a One Health priority research agenda. This was built on 5 pillars. One of them is behavioral insights and change. This was an attempt to catalyze more interest in this area. Also in WHO, there's now an internal consultancy called Behavioral Insights, which will try to help other programs in including this. But I would very much like to welcome your advice how more systematically this aspect could be included and accelerated, because I think most of you have mentioned that the behavioral insights, the human behavior, is key to any change in AMR. So what would you suggest to accelerate this aspect?
Anyone?
I think it starts with funders, and I think it starts with, you can only do research. I'm not talking about service provision, but if we need research, this starts with what funders are willing to fund and what they will insist on funding. And I see increasingly funders, certainly in the UK, talking about an insistence on having behavioural aspects actually hardwired into the programme. They're quite difficult to review, actually, as it happens. I've been on panels where we've been trying to review, a complexity of a programme. But an easy, perhaps, answer in the first instance is we have to ask our funders to make sure that that's hardwired into any application. It's not the only answer, but it starts.
And a short one, short?
And we have to take it on us. Who's done an intervention study or something that would imply behavioral change without a social scientist involved? Yeah, I have. We're trying to we have to get them involved more. I think we're getting better progress with that, but there aren't a lot of them. And there aren't a lot of trainees there. Like, we should have 10, 20 social scientist trainees in this room right now, if not more, that are working on behavioral interventions in medicine. And that's going to be a slow process, but if we don't engage them early and get them interested, because the social scientists out there are busy, right? We're not going to have 100 coming to our door. We've got to build that expertise with them.
Thanks a lot.
Hi. I'm Dr. Anusha from India, clinical microbiologist and chair of infection control. So in continuation to all the questions that you asked, the crowd that we are here, we are very aware about AMR. We are battling it every day. So we could talk about it till the cows come home. But the question is that the people who are prescribing, the clinicians and the other group of people, unless we engage with them, we are not reaching anywhere, because every time when I go on my rounds, I have questions like, you have everything resistant, so what do we do? That's a very simple question to ask at very late in the game. So how can we engage with other groups? Because I think that's where we have a huge lacunae.
Anyone would like to share?
I cannot answer the question for the place where you work. I can only tell you where I work. I come from the Netherlands, where clinical microbiology is an integrated part in the hospital. So the clinical microbiologists work with the infectious disease specialists together in the consultation of the patients that need antibiotics in the hospital. So there is that connection, and there is that direct connection with the other specialists that prescribe the antibiotics or that ask for an advice. And in that system, you can bring in all kind of, let's say, measures to better prescribe antibiotics. Every hospital in the Netherlands now has an antibiotic stewardship team, an A team. Came from a very good television series. And their responsibility is to do surveillance on antibiotic use, identify problem areas of prescription, and target the problem. But that's where I work. That's not the situation that you are in.
Thanks a lot. Lance Price?
Lance Price from GW. I just have to say now, because you mentioned the A-team, I pity the fool that misuses this antibiotic. Okay, so my question has to do with market failures. So we talk a lot about the market failures associated with not bringing new drugs to market. But when it comes to diagnostics, it seems like there's a huge market failure. diagnostic companies won't bring new diagnostics that we need, these rapid point-of-care diagnostics, to market if doctors don't use them, and doctors won't use them if they're not reimbursed. And so in our dysfunctional system in the United States, where we have these independent payer systems, the insurance companies, they're not reimbursing for these. They won't reimburse for these tests. They have a flat rate for a visit to an outpatient clinic, and if they order a diagnostic, that cuts into their profit, right? And so what's always confused me, though, is why this market failure does this market of failure exist in socialized medicine in European countries, or what's keeping these from coming to market here?
Sharon, I think you may be the best one.
Perhaps not. I think every country has its own system for introducing diagnostic tests into their healthcare system, so I don't think there's a single answer. But certainly in the UK, the introduction of a diagnostic test would be based on evidence that it works really well, and then an evaluation of, so there would be kind of guidelines as to what you can introduce. But what I would say is that when something works really well, it will catch on like wildfire. So MALDI-TOF, for example, was a new technology. It came into the lab for bacterial identification, and everything, it was introduced relatively rapidly, certainly in the UK. And so I don't think there's one size fits all, actually, to that response. Other people may have a better...
No, but maybe one just kind of ancillary thing is one of the problems is getting people to recognize the value of them. Because if they use a test and your patient gets better quicker, you realize that's value. If you use a test and things just don't go wrong, you don't recognize that. So it's harder to get people, again, it's that motivation factor. But if you're trying to use a test to refine treatment, if you give everyone antibiotics, they're all going to get better the same. If you start refining antibiotics, you might do it really well, but they're not going to actually observe the difference or recognize the difference. So I don't think there's an easy answer.
Difficult one.
I think the sad thing is that in the U.S., an antibiotic's $5 and a diagnostic is $80, so it won't work.
Thank you.
Hi, I'm Katarina Pärnänen from Finland. I have a question and then a few kind of ideas and comments. The first question is, what's your idea on wastewater monitoring, or something that pulls sort of everything from the community and translating that to prescriptions in the hospitals? And then secondly, related to production animals, in Finland we haven't used any antibiotics for poultry for decades. So that's kind of an example that it's possible, but what I hear from colleagues who've worked in the US, the statement is that it just doesn't work here, but obviously it's possible to make it work. And then thirdly, about human behavior, I'm currently working on a cohort of 7,000 and plus adults from Finland, the FINRIS cohort, and there we have follow-up data nearly 20 years from the first sampling. And we see that if you have a lot of antibiotic resistance genes in 2002, then you're more likely to die of all-cause mortality in the following 20 years. So maybe that's something that might motivate the prescribers and also the general public as thinking of it as a risk, kind of the same as something that might cause cancer in the long run.
So, short comment on the wastewater. Is anyone here?
I can take the wastewater.
Yeah. You take the wastewater. Yeah.
That's
Please.
my life. So, yes, big issue, wastewater. And I think the environmental aspect of AMR needs to be understood in terms of both waste coming out of animal farms, but also out of hospitals and manufacturing facilities. And that's an issue of concern. It's also an issue where prevention comes in again, because it's very difficult to treat antimicrobials in wastewater after you've contaminated. So that's really the big challenge in terms of reducing the use, because treatment is very expensive in our part of the world. It's also a fact that we want to use the waste for other uses. We don't have the luxury of dumping poultry waste and incinerating it. We need to use poultry waste back on the land. And that again means that you need to minimize the use because you want to reuse, you want to be able to reutilize and do better resource management. So critical issue.
So I'm very sorry, but we are running out of time. So I know that you were standing there for quite some time, but we're really running out now, and we need to hand over at the end to Hailey to give an overall. So I just want to close this session here with two comments on what I've heard. First of all, we really need to take the word multidisciplinarity much more serious in this one here. We need not only behavioral or biomedical, we need behavioral, but we also need economical. And nobody asked how many economics are in here, but it really is crucial, especially when we are going to speak to Sunita and to Chris. Secondly, we need to have ownership of the problem. That ownership needs to be up here, but it also needs to be both at the public, but especially at the policy side. And then finally, given that we are speaking clinical microbiology and infectious diseases, clinical microbiology and not only infectious diseases, but all clinicians need to learn to work together closely, because otherwise we will not have a chance to fix it. And the final word for me is, remember, there's a huge issue or difference between low and middle income countries, the availability of things there, and the high income countries. And we need to get everybody on board. If we're not all on board, nobody is really safe. So with this, I will give it over to you, Sunita, to end up this panel here.
Thank you, Robert. And I think it's been a fascinating panel. So we should firstly give the panelists a big hand. I think beyond what you have said, to sum up, I'd just like to focus on the word behavior change, because that has come up a lot in the conversation today. And as an environmentalist, somebody who's worked on climate change for decades, I think one of the lessons we need to learn from another global crisis is that bringing behavior change is difficult unless you first know the state of the crisis, you understand the urgency of it, which is where diagnostics plays a role, which is where surveillance plays a role, which is where the question of trust plays a role. Because when the other side is telling you there's a problem, you need to be able to understand that it is indeed a serious problem that needs to be dealt with. But the other big issue that comes where behavior change comes in is when you have options, when you have alternatives, when you can give people ideas of what they can do so that they don't have to take the antibiotic, but they can still get well, that they can use tests so that they can do early disease detection so that they do not have to use it, so that there is clean water, there is sanitation, there is no pollution load or less pollution load, so the respiratory ailments go down. So we need to make those linkages and find solutions, because exactly as you said, Robert, this is something that needs to be understood in its multidimensional role. So I think thank you very much for listening to all of us. I think it has been a fascinating panel to make us understand both the human and the animal side, and the role that diagnostics can play, innovation can play, in helping us to deal with what is truly a global pandemic, and a silent pandemic at that. So with this, I'd like to invite Dr. Hailey Getahun, who's the director of the Joint Secretariat of the Quadripartite, which is, as you know, an organization of WHO, UNEP, OIE, and FAO. Hailey, the floor is yours.
Thank you. Thank you. Thank you, Sunita. Thank you very much also for this session. And my presentation in the next 10 minutes, since this is the first time that we are bringing decision makers, policymakers, and academia and research, we want to conclude with key message. And the key message is building on an upcoming opportunity where politics can define how we are going to manage the AMR crisis, at least for the next decade, as we have done for the last decade. So my key message is there should be specific commitment to increase investment in research and development are needed, and professional societies like ECCMID, researchers and academia should play a key role. And I hope I will convince you at the end of my presentation. So what are health-related UN General Assembly high-level meetings? In the last 2 decades, there were almost 10 high-level meetings related to health agenda. On HIV/AIDS, there were 4. And the first one, actually, what is called the UN General Assembly Special Session, UNGAS, and it was for HIV in 2001. And then for non-communicable diseases, there were 3 high-level meetings, and then 1 each for AMR, TB, and UHC. So these high-level meetings are actually major events to engage heads of government and heads of state for that special agenda, and particularly to get their support for intensifying efforts, particularly around financing. And all these high-level meetings, they will have their political declaration, which is negotiated by all 194 countries of the United Nations. And all these political declarations always start, we, heads of state and government, and the representatives of states and governments assembled at the UN. So this really is a commitment from the heads of government, from the highest political structures. So are these high-level meetings useful? Is it worth to invest time? So I would like to demonstrate how impactful they are by showing the example of HIV/AIDS. There has been quite, as I said, HIV/AIDS was the first high-level meeting, 2001, and the highest also it has over the last 2 decades. So immediately after the high-level meeting, there has been a lot of resource available. And PEPFAR was established by the then President Bush of the United States of America, which so far actually invested $100 billion USD on HIV/AIDS interventions in 50 countries, and it saved 21 million lives. Similarly, following the high-level meeting, the Global Fund for HIV/TB Malaria was also started in 2003, and so far, only Global Fund, 30% of international fund goes to HIV, and they invested nearly 24 billion in programs. And also in TB/HIV, that the overlapping has been also invested in 5 billion. So this is the impact of high-level meetings, mobilizing resources. But also the impact of this development funding, as you can see on the last row, the bar graph actually is how is currently, this is 2021 data on HIV/AIDS investment, and there was 21.4 billion available and invested on HIV interventions, and 60% of this came from low and middle income countries, from domestic financing. So this really shows how the commitment finally actually goes into sustainable funding and financing and policy action. So this is from a paper that was published last year, really to show how much they are also in terms of impacting mortality and morbidity. This is, they really tried to show, except for the AMR1, you can see all the others, with more investment in blue, a reduction in the burden of the disease it comes. But here, it could also be because we don't have enough reliable data for AMR until recently when they do this analysis. So there is no question. The 2016 political declaration was a major milestone for AMR. This is just to summarize what has happened in the political sphere. The quadripartite working together, addressing AMR across the whole scenario, and today's meeting is also a reflection of that, having several issues, several sectors covered, and then also running into the next follow-up of high-level meeting in 2024. Not only that, the 2016 political declaration has also resulted into new initiatives, particularly for public-private partnership. CARBEX, which is now giving resources for preclinical development, was established in 2016. The same with GARDP, looking for clinical trials. AMR Industrial Alliance, which consolidates the role of the private sector, was established in 2017. The Global AMR Research and Development Hub by G20, led by Germany at that time, was in 2018, and REPAIR is a Novostock Foundation, private research support. So you can see, this really resulted in the engagement of public-private partnerships. The impact is huge. And the graph, as it was mentioned earlier, also shows that actually the commitment, the specific commitment for countries to develop national action plans has paid off. And we have more than 170 countries developing national action plans. But only 10% of those were funded. So that means there was a problem in terms of mobilizing resources, the 2016 one. So that is exactly why, when you look into the 8 specific commitments in the 2016 declaration, the declaration, there is a background statement of narratives, and then there is a section of 8 commitments. In the 8 commitments, you don't really see much more specific call for any financing. And then recently, when all those national focal points responsible for implementation of national action plans, when they were asked, what is your major problem in terms of implementing national action plans, you can see in this word cloud that funding comes the real challenge and problem. What about research? When you look and do the word cloud in the commitment part of that political declaration, this is, in the 8 commitments where member states and governments, heads of states say, we will do X, Y, Z. You see it represented here in a small box. But when you look into the narrative where there is no commitment, it's a little bit, mentioned higher, which means it is more of lip service rather than actual commitment. So this has to change. So that's why when you look also from the paper that I mentioned earlier, what is the peculiarity of the 2016 political declaration on AMR? It is 2. 1, there was no target. And number 2, there was no organization to follow through the implementation of that political declaration. Whereas for all HIV, we have UNS, we have WHO, NCD, and the others, we have WHO. But for AMR, there was no specific entity and organization, which actually helped after its establishment with the joint secretariat that I am working has been established as a result of the political declaration. So the Global Leaders Group discussed this intensively in its meeting in February in Barbados. And these are the 7 areas that they have identified that we need to start conversation, really to have specific commitments as part of this political discussion and negotiation as it happens in 2024. The first one is all about financing. As I mentioned, these high-level meetings should result availability and commitment around financing. And the financing here, what the Global Leaders Group has put is we need 2-pronged approach for the financing. One would be for the National Action Plan implementation, for having a specific financing mechanism, but the other one to address the pipeline and access crisis. I will repeat, it's pipeline and access crisis, which means it's about the research. And we have also heard quite a lot from Scott earlier, how much the imbalance between investment in research and even having, what is the best model of having an animal production without use of antimicrobials, and the alternatives to antimicrobials could really result in the reduction in the use of antimicrobials in the agri-food system would also help. And the other one is the targets and also transforming the systems. So, in conclusion, the ANGA 2016 was, of course, a major milestone, as I mentioned earlier, but still AMR is a problem, because our financing issue has not been addressed, be it for implementation or be it for research and development. So we have to seize the opportunity of ANGA 2024 to solicit much more specific commitments for this political declaration to bend the tide of the AMR. That's why we need national, regional, and global professional societies, academia, and the AMR's research community should add your voice in these negotiations as they happened in your nations, in your countries, in your global forum, to make sure that there is much more specific commitment when the member states meet together next year. Thank you very much.
I think it gave us a fantastic overview of the different needs we had. The discussion was great. And to sum up, there's 3 key messages we need. First of all, the money. We need the research and the multidisciplinarity, really to move this ball forward and keep going. I thought the discussion was really fantastic, and this was thanks to the audience being here. And with that, I would like to hand over to my co-chair.
Thank you. Thank you very much, Annelies, and thank you for all the panelists and for all of you who have been here today and those who have followed us online. Now, the Global Leaders Group in the last 2 years that we've been around has been to many different fora and has coordinated and has liaised with a lot of different fora, with the G7, with the G20, with the United Nations United Nations General Assembly, with the heads of government meeting for Commonwealth leaders, and many others. But today's meeting is exceptional, and I think today's meeting is extremely important, because the people in this room and your society is where the science is coming from. It's where the evidence is coming from. It's where the data is coming from, which will allow policymakers to make the right decisions and to shape the way that we tackle AMR. So once more, thank you for inviting us here today. Thank you for participating so actively in this afternoon's discussion. And yes, let's keep the discussion going beyond this room, beyond today, because we have a crisis in our hands and we need to tackle this together. Thank you very much, and we wish you a good night and a good conference.
There's there's a ceremonial networking session afterwards, so we'll keep the discussion going. And in the name of GLG and ESCMID, many thanks for attending, and keep the flow going. Goodbye. Thank you.
Thanks, Amy.